मॉर्निंग सर।
गुड मॉर्निंग। मैं वो ये लगा के देखता हूँ होता है क्या, वर्चुअल बैकग्राउंड कैसे करने का रे?
आपके पास है सर वर्चुअल बैकग्राउंड?
नहीं, मेरे को देना।
सब भेज दो।
हाँ, भेज दो। मेल पे भेजना। सर वो ये कैसे लगाने करे, वर्चुअल बैकग्राउंड? हाँ, मिल गया, रुको एक
सर वो आपको नीचे स्टार्ट वीडियो स्टॉप वीडियो का ऑप्शन आ रहा होगा, स्टॉप वीडियो का ऑप्शन आ रहा होगा, देखिए नीचे में।
या मिल गया, एक मिनट। गुड Good morning, everybody. I welcome you all to this second day of Sepsiscon 2022. We will start with exciting lectures today. The first lecture is by Professor Atul Kulkarni. It is on hemodynamic fluid resuscitation in low resource ICU. Over to you, Dr. Atul Kulkarni.
Good morning. We'll be talking about fluid status assessment in ICUs located in low resource countries. In the next 25 minutes, I'll be talking about the dilemmas in fluid therapy, utility of clinical examination, the most commonly used parameter for volume status assessment, the central venous pressure, fluid challenge test, passive leg raising, and the summarize matter. For achieving optimum fluid balance, it is important that we assess the volume status of the patient and whether the patient is fluid responsive, because we know the risks of volume depletion as well as the volume overload. Volume depletion can lead to decreased organ perfusion, shock, and multi-organ dysfunction syndrome, whereas volume overload can cause impaired oxygenation, tissue edema, organ congestion, and the attendant problems. The most important part of assessing the patient for volume status is clinical examination. Unfortunately, the art of clinical examination is being forgotten. Starting with this article published in 1999 in JAMA, up to very recent period, there are multiple articles which describe how to assess clinically whether the patient is optimal volume status or not. Apart from the usual vital signs of pulse rate and blood pressure measured non-invasively, a 30% drop in blood pressure from changing the posture from supine to sitting up or standing suggests presence of hypovolemia. Apart from this, physical examination including mentation of the patient, capillary fill time, skin texture dryness, skin perfusion, mucosal dryness of the axilla, particularly in elderly patients, temperature of the extremities, and the temperature gradation from core to periphery, and urine output are the commonly suggested tests for clinical assessment of volume status of the patient. So there are these 5 windows to circulation where obtundation of the patient or confusion or lethargy or drowsiness suggest decreased perfusion to the brain, and the patient must be assessed for hypovolemia in such circumstances. Then have a difference in the core and peripheral temperature, which again suggests a drop in the volume status of the patient. And as you infuse fluid in these patients and the circulation improves, this gradient should decrease. You can just look at the grade 2 temperature and whether it warms up after infusion. You can look at the mottling score or the skin color changes around the knee and capillary refill time, and urine output has been termed as the poor man's cardiac output. So how to perform the capillary refill time examination? Position the patient's head at the level of the heart. Apply pressure to the fingertip for 5 seconds, and after releasing pressure, the fingertip which is blanched should perfuse within 2 seconds. So this paper suggests describe the taste, capillary refill time in pediatric patient, and suggested that if the capillary refill time is less than 2 seconds, it is normal. If it is more than 4 seconds, it's abnormal. And if it is between 2 and 4 seconds, then that should prompt further clinical examination to assess whether the patient is in shock. A capillary refill time more than 5 seconds indicates inadequate cardiac output, and a refill time of more than 2 seconds can indicate poor skin perfusion, a sign that may be helpful in early septic shock. In mottling score, you look at the color of the skin around the knees. 0 indicates no mottling, whereas 5 indicates presence of mottling across the groin fold. And cannot be used for dark skinned people. So the skin mottling score, 0 indicates no mottling, 5 is a grave sign and indicates when it's seen when the mottling extends beyond the fold of the groin. Now, as this patient is hypovolemic, presents to you with severe or grave mottling, you start giving food to the patient and the color of the skin improves, tells you that your resuscitation is working. Now, I said that this cannot be used in dark skinned people. So in dark skinned people, you can use what is called as laser Doppler imaging. Obviously, it's not going to be available in the low resource setting, but you can see in patient A, after resuscitation, the score has decreased from 5 to 3. That means this patient is improving. Whereas in patient B, a score of 0, which means no mottling, the patient is worsening. Another important test that can be used very easily at the bedside is capillary refill time, if it is performed correctly. And there have been multiple investigations which suggest that capillary refill time can be useful not only for clinical examination but also as a strategy during resuscitation. In fact, Andromeda Shock 1 trial looked at the resuscitation strategy which targeted capillary refill time versus strategy of lactate clearance on the mortality in patients with septic shock, and found that capillary refill time was almost as good, if not better, as compared to the lactate targeted therapy. Other important clinical parameter can be temperature of the great toe or skin temperature and core peripheral temperature gradient as marker of hemodynamic status. Apart from hypovolemia itself, you can have cold peripheries without hypotension, and that limitation must be kept in mind when you are assessing the patient using these parameters. So if you get a low skin temperature or peripheral or high core peripheral temperature gradient, it should not be considered in isolation when assessing cardiac status until these are validated by further large-scale prospective studies. Coming to the probably the most commonly used parameter called volume status assessment, that is central venous pressure. Now, central venous pressure is supposed to refer to what is called as preload of the left heart. So it is going to be affected by myocardial contractility, volume of the blood, the afterload of the left ventricle, the venous tone and ventricular compliance. But when we measure the central venous pressure, we make multiple assumptions, most of them from their own fellowships. So we are actually interested in the volume of the left ventricle at the end of diastole. Here the first assumption comes into play when we equate volume with pressure, and they're actually not linearly related. The second assumption we make is that the right atrial pressure or pulmonary arterial oxygen pressure reflect the left atrial pressure. Also, that left atrial pressure reflects the left ventricular endoscopic pressure, and both are obviously not going to work if there is a valvular problem in between. We also assume that the pulmonary arterial oxygen pressure reflects the pulmonary venous pressure, and here the assumption is that it is no pulmonary venous hypertension. So if all these assumptions are true, then central venous pressure probably reflects the left ventricular endoscopic pressure. The other question is now, assuming that the central venous pressure actually reflects the volume status of the patient, if there are inaccuracies of measurement, then we will be led astray, and therefore we must be sure where to measure the central venous pressure. The peak of the A wave on the central venous pressure coincides with the point of maximum filling of the right ventricle, and therefore this is the value which should be used for measurement of right ventricular end-diastolic pressure. Do not take the readings that you see on the machine to be the central venous pressure, because the machine is just going to average the measurement, and all of us know that it should be measured at the end of expiration. So if the patient is spontaneously breathing, that means that the central venous pressure and the respiratory curve is going to be at a lower point as compared to the expiration, which is closer to the zero, and therefore the pressure should be central venous pressure should be measured at the end of expiration. This is reversed when the patient is on positive pressure ventilation, where during the positive pressure breath, the higher part will be the inspiration on the monitor, and the lower part will be the expiration, or as close to zero as possible, which might include the peak that you are applying, and therefore the central venous pressure should be measured just before the beginning of the next inspiration. Another important concept is that we measure the pressure inside the vein when we are measuring the central venous pressure. So, for example, if you have penetrated the interjugular or subclavian vein, as long as the tip of the catheter is inside the thorax, we take that as the central venous pressure. However, we must remember that the heart and the great vessels are within the pericardial cavity, which itself is in the chest, and if there is increased pressure inside the chest or the pericardium because of some reason, such as pleural effusion or pericardial effusion or pericardial tamponade, then the CVP will be positively limited. So for the same preload or for the same volume, the measured value of the central venous pressure will be increased. We are all familiar with the Frank-Starling curve, which explains the length and force relationship of muscle contraction. Since heart is a muscle, there is no reason why this should not apply to the cardiac contraction. So on the x-axis, we have the preload or the end-diastolic volume. On the y-axis, we have the stroke volume. And when we draw the curve, Frank-Starling law states that within physiological range, with increasing amount of end-diastolic volume, the stroke volume will increase. So if you relook at the curve again, you will find a steep portion of the curve where the patient is supposed to be on the preload dependent part of the curve, which essentially means that if you increase the CVD in this patient, then the stroke volume will increase as compared to the plateau portion of the curve, where The patient is said to be preload independent. That means that if you give fluid, only the preload or the pressure will increase, but not the stroke volume too much. You can have a family of curves depending on how the heart function is. For example, the one at the bottom is the failing heart, and one at the top is the hyperdynamic heart. And if you measure a single value, or if you measure central venous pressure at one point, you will get a number which will not tell you anything because you do not know the status of the heart, and therefore that single value of CEP cannot indicate the preload. If you measure it after an intervention, subsequently after giving say fluid or vasopressor, then the trend will tell you how the central venous pressure is changing in response to your intervention, and that may indicate whether the volume status is improving or not, and whether the cardiac output is increasing or not. So there are multiple studies which show that the single value of central venous pressure can be the same in patients who are responders or non-responders to volume therapy. So what is fluid responsiveness? Fluid responsiveness is when the patient increases his cardiac output in response to a fluid bolus or fluid infusion. An ideal world, we would like to identify fluid responsiveness before giving fluids so that we can avoid the adverse effects of giving fluids. Just to reiterate, the single value of CEP or pulmonary arterial volume does not predict fluid responsiveness because the area under the curve is around 50%. So what do? We can challenge the cardiovascular system by infusing fluid to see how the central venous pressure behaves, and that is called as the fluid challenge test. It was first described in 1979 by Weil and Hinney. So measure the baseline CVP, look at the value, and depending on the value of the CVP, infuse a colloid in a peripheral vein and look at what happens to the central venous pressure during infusion and at the end of the infusion. So if the CVP rise is less than 2 centimeters water, continue giving fluid. If the CVP rise is more than 5 centimeters of water, stop giving fluid. If the CVP rise is more than 2 but less than 5, wait for 10 minutes and check CVP again. If the CVP rise comes down to less than 2, continue. If the CVP rise is greater than 5 centimeters at the end of infusion and does not come down at the end of 10 minutes, stop giving. However, the older way of doing fluid challenge did not include the objective and the limit, and therefore a new type of fluid challenge was described, which consisted of 4 elements. You decide what type of fluid you want to give, what is the rate of infusion, what is the objectives that you want to achieve, and what is the safety limits. So, for example, type of fluid is Ringer's lactate, rate of infusion is 500 ml over 30 minutes. The clinical endpoint is MAP of 75 millimeters of mercury, and pressure safety limit is 15 millimeters of mercury. So if you started with a baseline MAP of 65 and CP of 10 millimeters of mercury, at the end of 10 minutes, the MAP has increased, but CP has not increased too much. You continue to give fluid, and at the end of 20 minutes, you stop giving fluid because your MAP is achieved and the safety limit is not exceeded. And this fluid challenge is a successful fluid challenge. As against this, starting with the same numbers, if at the end of 10 minutes the MAP is increased and CB is 40, you continue to give fluid. At the end of 20 minutes, the MAP is 60 millimeters of mercury, but the CB is now 50. You should stop giving fluid because this is an unsuccessful fluid challenge, and we probably need to look at some other therapy. So if at all we have to do fluid therapy, you need to decide how much fluid to give. So this interesting study by Chekuni et al. Looked at the different doses of fluids for a fluid challenge, and they found that a minimum of 4 ml per kg fluid is required to get a good response from the fluid responders for a successful fluid challenge. A meta-analysis by the same group again published in 2017 looked at the impact of fluid challenge technique on diagnosis of fluid responsiveness, and they found that the duration of the test should be short and not very long. Something else that can also be done at the bedside is infusion of 100 ml of colloid over 1 minute, which is called as a mini fluid challenge. So the study was a small study, it was a proof of concept study. So the patients were given 100 ml fluid challenge over 1 minute and looked at the change in aortic flow velocity time integral at 1 minute. A VTI of more than 10% predicted fluid responsiveness with significant sensitivity. However, the best test which can be done spontaneously breathing patients with arrhythmias is called as the vasovagal test. They often use it in patients where to vasovagal attacks, where we just elevate the leg of the patient since the volume is transferred to the central circulation. The patient's vagal tone is restored, the volume is restored, and the patient feels better. The same principle was applied by Professor Munia and Tegu. And so, how do you perform this test? Put the patient in semi-recumbent position, remove dead stock if they are present so that the blood can pool. After waiting for 5 minutes or 10 minutes after removal of the dead stockings, you rotate the entire bed so that the patient is not disturbed and that disturbance or excitement does not change his cardiac output and the heart rate. Wait for 60 seconds. Look at the change in cardiac output or stroke volume. After 60 seconds, come down to the semi-recumbent position again by turning the bed over to see that the pre-test status has occurred, and then if the passive grazing test is positive, that means the cardiac output has increased by 15%, then we can actually do volume expansion in the semi-recumbent position and see whether the aortic blood flow has increased by 10% after giving the volume infusion. Now, since we are talking about resource limited setting, where the measurement of aortic blood flow is not likely to be available, while describing this stage, Professor Temple and Professor Monet said that a PLR increase of greater than 12% in the pulse pressure, which signifies the increase in stroke volume, also predicted to responsiveness, but with lower sensitivity and specificity. So to summarize, assessing volume status of patients in shock is essential for preventing complications over or underfilling the patient. The 5 windows to circulation or the clinical windows to circulation are extremely useful. Mental obtundation and drop in hourly urine output are early indicators of low intravascular volume. Capillary refill time and peripheral to core temperature gradient are very useful and may even help in assessing response to therapy. Though single only of CVP is not useful, its strain can be useful. Appropriate measurements must be done to avoid interpretation error. At least 4 ml per kg colloid infused over a short duration will correct target and safety limit should be used to perform a fluid challenge. And passive leg raising test with change in pulse pressure can be used to predict fluid responsiveness in resource limited setting. Thank you very much for your time.
That was an excellent lecture by Dr. Atul Kulkarni. We'll move on to our next lecture, which is by Professor Tabul, which is on the future of fluid resuscitation. Over to you, Dr. Tabul.
Hello, ladies and gentlemen. I'm Jean-Louis Teboul from Paris, France, and I'm very honored to participate in this online conference. And I thank a lot the organizers for their kind invitation. So I will speak about the future of fluid resuscitation and should we use microcirculation guided resuscitation, at least for fluid. I have no conflicts of interest for this presentation. So the current way to manage patients during the early phase of septic shock in terms of fluid administration is more or less this one. We should give fluid at the initial phase, of course, and we should individualize our fluid administration based on a clinical context, on clinical signs, on comorbidities, etc., etc. And if shock persists, it is time to test product responsiveness using whatever you want. There are now many dynamic indices of product responsiveness, and we can continue fluid administration if the patient is fluid responsive, and if the patient has some ARDS, we also should need we should need to assess the benefit risk of fluid administration and give fluids if the benefit is higher than the risk, of course. In case of unresponsiveness, we should choose other therapies. This is a traditional way to manage patients during the early phase of resuscitation of patients with septic shock. And the question is, should we add much round of microcirculation in this decision-making process? Why? Because we know from more than 20 years now that microcirculation is altered in patients with sepsis. This is a study by Daniel de Backer comparing volunteers and septic patients in terms of microcirculation of the sublingual territory. And they use, as you know, this video microscopic technology looking at the microvessels of just in the sublingual area, and they could use some variables like the proportion of perfused small vessels, which was here lower, significantly lower in patients with sepsis, and it was the same for other parameters of microcirculation. In fact, this microvascular dysfunction is essentially due to endothelial cell dysfunction, due to dysregulation of the motor tone, of the arterioles, of capillary recruitment, procoagulant activity leading to microthrombosis, and also release of pro-inflammatory and pro-adhesive substances. And all these anomalies can result in microvascular dysfunction. What are the arguments in favor of monitoring the microcirculation during the early phase of sepsis? First, we know now that microcirculatory dysfunction contributes to tissue hypoxia. In fact, all these anomalies result in decreased capillary blood flow and decreased tissue oxygen delivery, and increased capillary permeability, resulting in alteration of oxygen diffusion and oxygen extraction. Another argument is that microcirculatory dysfunction occurs early during the septic course, and this was confirmed in patients with septic shock. This is a study performed in the emergency department of an American hospital, and patients were studied during the first 6 hours of resuscitation. And the authors also measured microcirculation variables at the level of the sublingual area using the same technique as used by Daniel De Backer before, the vital video microscopic technology. And as you can observe, the flow velocity score was lower in patients with sepsis compared to controls and lower in non-survivors compared to survivors. The same for capillary density of the sublingual microcirculation. Another argument is that microcirculatory dysfunction may persist in spite of correction of macrocirculatory disorders. And this is illustrated by the study by Daniel De Backer again. After the initial phase of resuscitation, they could correct systemic blood flow variables like mean arterial pressure, like cardiac index, or like SVO2, which is now 68%. And at that time, they measured microcirculation of the sublingual area, and they found that microcirculation was impaired in spite of correction of the systemic blood flow variables compared to volunteers. And this is a proportion of perfused vessels, the small vessels. So in spite of normalization of systemic blood flow, still microcirculation was impaired in this study. And also the persistence of microcirculatory dysfunction is associated with a poor outcome, and this is well illustrated again by a study by the same group, by the group of Daniel De Backer and Jean-Louis Vincent. It's a study also authored by Yasser Sacker. And this study, they looked at the sublingual microcirculation using the same technology, but not only 1 day, but 7 days. And they look at the evolution in survivors in black and non-survivors in blue. And they found the proportion of perfused small vessels, which was identical on day 1, improved in survivors, but did not improve in non-survivors. There is a consensus paper on the assessment of sublingual microcirculation in critical patients, and this is a task force of the European Society of Interventional Medicine. And the experts essentially talk about the assessment of sublingual microcirculation, and they propose what are the relevant variables to look at, and all the technical problems we have to face, and also all the possibility of further developments of this technology. What could be the arguments not in favor of monitoring the microcirculation? First, at the early phase of sepsis, there is no clear dissociation between macrocirculation and sublingual microcirculation. And this is well illustrated again by the study I already talked about. This is a study performed in the 6 hours after admission of the patient at the emergency department. As you can observe, the microcirculatory indices are well correlated with MAP, with SVO2, and with the cardiovascular surface score, indicating that during the initial phase, microcirculatory disorders are still dependent on systemic circulation disorders. And of course, it's not absolutely necessary to monitor microcirculation if they are if the variables are well correlated to the usual systemic blood flow variables. Another argument is that during the early period of sepsis, correction of macrocirculatory disorders may also improve microcirculation. It is true in other situations than sepsis. This is a study we did in my hospital with the team of Jacques Duranteau in patients during major abdominal surgery. We try to detect all the episodes of hemodynamic instability during the operation, and we looked at pulse pressure variation as a marker for hemodynamic instability. And as you can observe, in some patients, there was episodes of increase in pulse pressure variation, which is normally associated with hypovolemia. And we gave fluids, FC for fluid challenge, and after fluid challenge, there was a decrease in post-pressure variation, so correction of this episode of hemodynamic instability. And we did not measure PPV only, we also measured stroke volume index, which decreased during the episode of instability and improved after free challenge. We also measure variables of the microcirculation of the sublingual territory using the same technique as described before. And again, the microair flow index decreased during the episode of instability, paralleling the increase in PPV, and also the same for pulmonary perfused vascular density, which decreased during the episode of hemodynamic instability, and all the microcirculatory variables improved after free challenge. So there is a parallel decrease of microcirculation variables and decrease in macrocirculation variables and correction after free challenge. What about sepsis? This is another study we did in my hospital with the team of Jacques Duranteau. We studied patients with septic shock at the early phase, and we performed PLR, passive leg raising, and volume expansion. We measured cardiac output, which increased during PLR and which increased after volume expansion, which is not surprising at the early phase of sepsis. But we also measure the sublingual microcirculation using the SDF technique, the video microscopic technology. And again, we observe an improvement in the proportion of perfused vessels with PLR and with volume expansion, an improvement in functional capillary density after PLR and after volume expansion, an improvement in microcirculatory flow index, MF5, during PLR and after volume expansion, and also an improvement in flow heterogeneity index, which decreased after PLR and volume expansion. So a parallel improvement in macrocirculation and microcirculation of the sublingual territory. Also, in studies showing persistent sublingual microcirculatory disorders, it is unclear whether correction of macrocirculation was optimal. Let's remember the study by Daniel De Backer showing that correction of the systemic blood flow variables was not associated with correction of microcirculation disorders. In fact, when we look at the variables obtained after resuscitation, we can ask the question if these variables are optimal. 71 maybe is not enough, in particular in patients with chronic hypertension. 68% for SVO2, in my opinion, is not enough. And maybe we can improve these variables by further resuscitation, either vasopressors or fluid administration, or maybe dobutamine. And maybe if we obtain optimal value or not suboptimal values, maybe we can correct microcirculation. This is a question we can answer. So I'm not totally convinced that correction of systemic blood flow variables is not associated with correction of microcirculation in the early phase of sepsis. Also, in large clinical studies, a normal sublingual microcirculation is uncommon. This is something which can be surprising, but which was demonstrated in this study performed in many ICUs, 36 ICUs worldwide, and 500 patients were included in this study. All these patients had assessment of microcirculation of the sublingual territory using the same video microscopy technology, and these patients were very severe. The in-hospital mortality was 28%, which is high, and surprisingly, only 18% of these patients had abnormal MF5, microvascular flow index, and also abnormal MF5 was not associated with in-hospital mortality. So this result is probably disappointing for the authors of this study, because all these authors recommended the use and still sometimes recommend the use of this technology to assess microcirculation, but in fact, there is no association between disorders of the sublingual area microcirculation, and mortality. And more importantly, there was big differences between survivors and non-survivors in terms of heart rate, MAP, hemoglobin, lactate, etc. Everything was different between survivors and non-survivors, but except for microcirculation, there was no difference in any variable of the sublingual microcirculation detected by this technology. No correlation, no association with mortality. Also, an argument to monitor microcirculation would be that at a late phase of sepsis, fluid infusion may fail to improve microcirculation. So it would be important to monitor microcirculation. And this is supported by this study by Gustavo Spinetta-Scon, Daniel Lubacker, etc. In this study, the authors looked at two categories of patients. Patients studied at the early phase of their septic disease, meaning in the first 24 hours. This is the early assessment of microcirculation, and they look at the proportion of perfused small vessels of the sublingual territory using the same technology. And also they looked at patients studied only at the late phase after 48 hours. There was a difference between the proportion of perfused small vessels, as you can see, which was better at the late phase. But when they performed a fluid challenge, they gave fluids. Only patients studied at the early phase improved their microcirculation of the sublingual area, while patients who were studied late did not change anything in terms of microcirculation. So these results are in favor of monitoring microcirculation during the late phase. The problem is that, as you know, fluid resuscitation is infrequently indicated at the late phase of sepsis, and in general, we resuscitate with fluid only at the early phase, the first 24 hours, or the first 48 hours and after. In general, it is not recommended because of the harmful effects of fluid overload. Importantly, another argument not in favor of monitoring the microcirculation is that so far the handheld vital microscopes still suffer from technical limitations. And importantly, the consensus paper in 2018 said that the two foremost developments that are required are firstly ease of image acquisition, which is not the case today, and also analysis of the images should be done rapidly, reliably, and automatically. Now it's not the case. And still in 2022, there is no big improvement of the technology to be applied for the routine practice, the daily routine practice, for example. And finally, another argument not to monitor is that the sublingual microcirculation does not reflect the microcirculation of vital organs. You know that the tongue is not an active organ. It's not a demanding organ in ICU patients who are, in the majority of cases, in particular patients with sepsis who are sedated and who do not use their tongue to anything. And in my experience, I saw many patients dying after severe hypotension, but exceptionally with tongue necrosis. And there are many studies that show that there is no correlation between the microcirculation of the sublingual territory and the microcirculation of other organs, for example, the intestines. This is an interesting study coming from the Netherlands. They looked at the same time at the microflow index of the intestines and the microvascular flow index of the sublingual territory using the same technology, vital video microscopy. And they found no correlation at all. And they also found no correlation in terms of changes with therapy of both territories. So the sublingual territory cannot reflect what is happening in the intestines. Another study coming from Argentina now found the same results. they measured at the same time the sublingual RBC velocity and the intestinal RBC velocity using the same technology, again, the handheld vital video microscopy, and they did not find any correlation. Also, they did not find any correlation for the change in sublingual and intestinal RBC velocity after a free change. And look at the R value, the Pearson R value equals 0.00. So it is very hard to do worse, of course. No correlation at all. And no correlation also for the perfused vascular density, neither for the baseline values nor for the change after a free change. And they also looked at the outcome according to in function to the sublingual microcirculation or to the intestinal microcirculation, and they found that there was no difference in terms of proportion of perfused vessels or microvascular flow index in survivors and non-survivors, why there was a big difference for the intestinal microcirculation with decreased in proportion of perfused vessels and microvascular flow index in patients who will die compared to survivors. Same results for other parameters like perfused vascular density, RBC velocity, or heterology index. So only intestinal microcirculation was correlated with outcome. Also, for the renal cortical perfusion, this study shows that the renal cortical hypoperfusion appears not be associated with changes in the sublingual microcirculation. So, what to do in practice? The consensus paper said that further developments are needed prior to its integration to routine clinical practice. They talk about the assessment of sublingual microcirculation. I would say that further research should be focused on developing technologies to assess microcirculation in more vital organs and establish criteria to determine when these anomalies are clinically relevant. I think that the more vital organs are more important for the microcirculation assessments. But what to do today? Today we have mottling and we have increased capillary fill time, which are used as trigger for fluid resuscitation, but also which are used as targets for fluid resuscitation. And let's remember the Andromeda shock study, this study by Glenn Hernandez and others, who compared two resuscitation strategies in septic shock patients. One strategy was based on peripheral perfusion status, mainly capillary refill time, CRT, and one strategy was based on the decrease in serum lactate in the first hours of management of septic shock. And interestingly, they found no difference in terms of death at 20 days, but the p-value was almost significant. The p-value was 0.06, and in favor of the skin perfusion markers. And also the SOFA score at 72 hours was better in patients resuscitated according to in function of the skin perfusion markers compared to lactate decrease. And another reanalysis, a Bayesian reanalysis on the Andromeda shock trial published in the Blue Journal 2 years ago concluded that there are very high probabilities that peripheral perfusion targeted resuscitation, essentially capillary fill time, may result in lower mortality and faster resolution of organ dysfunction when compared with the lactate targeted resuscitation strategy. So, how to answer this question, should we add monitoring of microcirculation decision-making process? I would say for my conclusion that first, assessment of microcirculation is important to better characterize the hemodynamic state, to have a more comprehensive picture of hemodynamics, of course. Regarding the question, is bedside monitoring of microcirculation important to guide fluid resuscitation septic shock? My answer would be not sure. For sublingual microcirculation, for the reasons I developed in my talk, yes, for skin perfusion, but we need to standardize the way to measure capillary fill time to have a relevant variable. And probably, yes, for more vital organs like the heart, the kidney, the liver, etc. But we need future technological developments to provide clinicians with bedside multimodal monitoring. So I would like to thank you very much for your attention, to say that it is nevertheless very difficult to predict what could be the future. Thank you very much.
After that excellent talk by Dr. Tibul, let's move on to the next topic, which is going to be delivered by Dr. Rajesh Pandey, and he's going to talk on why choose a map of more than 65 mm of Hg. Over to you, Dr. Pandey.
Good morning, ladies and gentlemen. In this 20 minutes talk, I'll be talking about why we choose a map of more than equal to 65 millimeter mercury, which has become a standard in our management of septic shock patients. So if we look at the septic shock, it is defined as sepsis with hypotension, which is refractory to fluid challenge and requires vasopressor. There's an increase in arterial lactate reflecting impaired cellular energy metabolism and dysoxia. So the lactate more than equal to 2, along with a refractory hypotension, which is, you have done fluid resuscitation, but patient is still in shock and requires vasopressor support, is classified as septic shock. And when we resuscitate these patients, we are basically trying to restore the tissue perfusion pressure. And at the same time, we don't want to cause excessive vasoconstriction, which will impede the flow and paradoxically worsen the organ dysfunction or may lead to other adverse events. So when you look at the mean arterial pressure, here you can see in this cartoon, we have two components. The heart has to pump blood against the systemic vascular resistance, which is largely because of the larger arteries. So the MAP has been defined as cardiac output into systemic vascular resistance plus CVP. For most calculations, we take CVP as near zero, near normal. So it basically translates into MAP is equal to cardiac output into systemic vascular resistance. So that gives us a physiological basis of mean arterial pressure. However, when you look at the way we calculate it practically, how your monitor does it for both non-invasive as well as, otherwise. So mean arterial pressure is the diastolic pressure plus 1/3 of the systolic minus diastolic pressure difference, or 1/3 of the pulse pressure. Now here in this arterial aortic waveform, you can see, now this is an aortic pressure here on this side, and this is the time, 1 cardiac cycle. So this is the dicrotic notch here. This is the peak of systole, and then you have the diastole. So the pressure here would constitute the mean arterial pressure here. And also you can see here in the right-sided cartoon that when systemic vascular resistance, this is the normal mean arterial pressure, cardiac output and mean arterial pressure relationship. When SVR increases, the mean arterial pressure increases. When SPR decreases, the mean arterial pressure decreases. So it's a key component of tissue perfusion, and often we consider it as a surrogate of organ perfusion pressure. And both are the Society of Critical Care Medicine and the European Society of Intensive Care Medicine guidelines suggest that we need to keep MAP more than equal to 65 millimeter mercury. and individualize this target based on comorbidities. Now, there are some concerns here. We know vasopressors we give commonly to patients who are in septic shock to avoid hypotension, which may be associated with myocardial injury, kidney injury, or death. But our concern is that vasopressors may reduce the blood flow in vasoconstricted vascular beds. They may have adverse effects on cardiac, metabolic, microbiome, and immune functions. So when we are treating septic shock and trying to maintain a MAP of more than equal to 65, we have to strike a balance between the risk of hypotension and the risk of vasopressors. So that continues to be a big challenge. Blood pressure most of the time is used as a guide. Mean arterial pressure is used as a guide for targeted vasopressor therapy. But the opinion has changed over a period of time. If you look at the 2012 surviving sepsis guidelines, the things were very, very clear. The target MAP of 65 millimeter mercury with a higher target for older patients and those with chronic hypertension and coronary artery disease. So 2016, when you see, they acknowledge that there is no evidence now for good evidence for targeting MAP values more than 65 in any patient groups. So that means we are still not very clear as to, we should target 65 or we should target more or we should individualize this therapy. So this talk will dwell on these aspects and will also focus on the research that has been done in these areas. Some of the studies, large scale, these were New England Journal studies, they found that MAP exceeding 65 millimeter mercury was frequently observed in large prospective randomized controlled trials, which were basically resuscitation trials focusing on septic shock. So these data suggested that patients had MAP in the range of 75 to 95, 24 hours after inclusion. So it's not uncommon to have a higher MAP in the, even in these high-class research settings. Then we had a large retrospective study published in Intensive Care Medicine, which showed that a MAP of more than 75 millimeter mercury may be required to maintain the kidney function. So should it be higher than 65? That is the big question. Well, higher blood pressure can be useful. This was confirmed by a smaller prospective observational study published in Critical Care. And then another perspective was given in the study published in BMJ, where they looked at, it was a physiological study looking at mechanism of chronic arterial hypertension, which showed that such hypertension causes a rightward shift in cerebral perfusion pressure and flow autoregulation, which might justify targeting a higher MAP in these patients. Now, when you look at this cartoon, now this is the normal relationship in healthy individuals. This is the autoregulation. This is organ blood flow on the y-axis, and you have here the blood pressure. So, this is autoregulated nicely here, so that the cardiac output and other things remain same, and the organ blood flow remains same. In chronic hypertension, it gets shifted to the right, as was suggested in the previous study. However, this may be lost in patient relationship, or autoregulation may be lost in patients who are in septic shock. So you see a linear relationship. So as the MAP is rising, you can see that the organ blood flow is rising. There is no autoregulation here. So autoregulatory mechanism is impaired in septic shock. Increased blood pressure will increase the organ blood flow. And another important thing is autoregulation will depend on the basal level of blood pressure, which will be higher in patients who are hypertensive. So optimal MAP target may differ, logically speaking, according to patient's medical history. So generally, when we are targeting a high MAP, the perfusion pressure increases and the venous circulatory pressure reduces. So if we look at the current surviving sepsis guidelines for vasoactive management, we use norepinephrine as the first line vasopressor, and we target a MAP of 65 millimeter mercury. And of course, we will also consider invasive arterial monitoring of the blood pressure. And plus, The consideration now is that do not allow patient to be hypotensive, do not wait for fluid resuscitation to be over and then start your vasopressor. So consider initiating vasopressors peripherally and simultaneously with fluid resuscitation. And then once central access is available, you can make a switch. Let us look at the evidence. So this was the Sepsiscon trial, the famous Sepsiscon trial, published in New England Journal, where they looked at high versus low blood pressure target in patients with septic shock. So this was a multi-center open-label trial where 776 patients with septic shock were randomly assigned to undergo resuscitation, either with a mean arterial pressure target of 80 to 85 or 65 to 70, which was considered a low target group. Primary endpoint was mortality at 28 days. The target mean arterial pressure was to be maintained for a maximum of 5 days or until the patient was weaned from vasopressor support. After that, target pressure was decided by the attending physician. Secondary outcomes in the study included 90-day mortality, days alive and free from organ dysfunction by day 28, and length of stay in ICU and hospital. So you can see the mean arterial pressure during 5-day study period. So this was the low target volume, low blood pressure target group, and this was the high MAP target group. And you can see the difference in the MAP. So this was between 65 and 75, and here it was higher than 80. So 85 to 90, that is what you see here. And if you look at the Kaplan-Meier curves for cumulative survival, you find that there was absolutely no difference in terms of survival, 28 days, 60 days, or 90 days. So the study concluded that in patients with septic shock, 28-day, 90-day mortality did not differ significantly between those who were treated to reach a target mean arterial pressure of 80 to 85 versus those where the target was 65 to 70 millimeter mercury. So essentially saying that targeting a higher MAP is not that bad. Another study from Canada looked at higher versus low blood pressure targets for vasopressor therapy in shock. Now, this was a multi-center because of the small number. This was a pilot randomized controlled trial. And this was called the OVATION trial, optimal vasopressin titration trial. The study design was published earlier. So what they did, they randomly assigned critically ill patients in vasodilatory shock, whatever was the diagnosis, to either a lower MAP, that is 60 to 65, or a higher MAP, that was 75 to 80 millimeter mercury. Primary objective here was to measure the separation in MAP between the groups. And they also looked at risk of cardiac arrhythmias, which they found was, 20 versus 36. It was percent. And hospital mortality were not different between the lower and the higher MAP arms. In patients aged 75 years or older, they found a lower MAP target was associated with reduced mortality, but such an observation was not found in the younger patients. This pilot study supported the feasibility of a larger trial comparing MAP targets below those applied in the Sepsiscon trial. So Sepsiscon, as you have seen, focused on the normal 65-70 target versus 80-85 target. Now here they say that even the lower values are better in patients who are aged more than 75 years. And they also say that further research may help delineate the reasons for vasopressor dosing in excess of prescribed targets and how individual patient characteristics modify the response to vasopressor therapy. That means we are still not sure whether it should be age-based or it should be individualized, or it should be one, single value of 65, because we found less is also good and more is also good. There was another recent trial. This was published in 2020 in JAMA, where they looked at effect of reduced exposure to vasopressor on 90-day mortality in older patients who were critically ill and they were in septic shock. This was a randomized clinical trial, and they wanted to determine whether reducing exposure to vasopressor through permissive hypotension So the same values that the previous trial had, Canadian trial, 60 to 65 millimeter mercury, reduces mortality at 90 days in ICU patients who are 65 years or older with vasodilatory hypotension. It was a pragmatic, open, multi-center, parallel group, randomized clinical trial that was done in UK, 65 NHS hospitals, which included general intensive care units. And patients who were more than equal to 65 years were admitted to these participating ICUs if they were eligible, and they were randomized within 6 hours of initiating a vasopressor infusion for vasodilatory hypertension with adequate fluid resuscitation to either the MAP target group of 60 to 65 millimeter mercury, which was called permissive hypertension. It had 1291 patients, or according to usual care. That is, it was left to the discretion of the treating physician, almost 1,300 patients. And the primary clinical outcome was all-cause mortality at 90 days. They had a lot of secondary outcomes. This study was called 65 study, famously called so. Secondary outcomes were mortality at discharge from ICU and from treating acute care hospital, duration of survival to longest available follow-up, duration of advanced respiratory renal support during ICU stay, days alive and free of advanced respiratory support and renal support within first 28 days, duration of ICU and treating acute care hospital stay. They also looked at cognitive decline as well as health-related quality of life. So when you look at the results, they found targeting a lower MAP in permissive hypertension group did not significantly increase the number of hours with a MAP value lower than 60. At 90 days, there was no statistically significant difference in all-cause mortality. Mortality at ICU and treating acute care hospital discharges were not significantly different, and there was no significant difference in time to death between the groups. The mean duration of ICU and treating acute care hospital stay and duration and days alive, free from advanced respiratory and renal support to day 28 were not significantly different. Number of serious events, adverse events were again not statistically significant. So they did not find any difference either in mortality or in secondary outcomes, ICU stay, respiratory, renal therapy, or cognitive and other dysfunctions. So here you can see the Kaplan-Meier survival curve. So practically this study meant that reducing exposure to vasopressors through permissive hypotension did not significantly reduce mortality at 90 days. Now it is up to us to interpret it either way. So basically all the trials that I have shown so far, we found that targeting, if you look at the Sepsiscon trial, targeting a higher MAP was equally good. If you look at the Canadian pilot study, targeting a lower MAP, 60 to 65 was good in patients more than 75 years, but they said that we need to validate the data in a larger series. Now here you find that if you are doing permissive hypertension 60 to 65, the Canadian target, then it does not significantly reduce mortality at 90 days. So it doesn't really help. There was a meta-analysis which was published in Journal of Clinical Medical Research this year, and they looked at the randomized controlled trials. So a lot of these trials were included up to 2020. And if you see when they are looking at the overall mortality, there you find that the diamond is very close to the baseline, and there are only 5 or 6 trials which fit into the scheme. So possibly we cannot find an answer, although it seemingly looks to favor a standard MAP. So what they have concluded here is targeting a high MAP goal in critically ill patients offers no benefit over current standard MAP goal in terms of mortality, duration of mechanical ventilation, and ICU length of stay. Another, data was published by Maheshwari et al. They collected data from the electronic health records retrospectively, and they looked at the association between MAP and acute kidney and myocardial injury, as well as in hospital mortality. All these patients were in septic shock. So they had a data of about 8,700 patients from 110 US hospitals. They define total exposure to hypotension as time-weighted average MAP and calculated cumulative time spent below 55, 65, 75, and 85 millimeter thresholds. So what they found was exposure to hypotension, that is time-weighted average MAP below 65, was directly related to hospital mortality. The longer time spent below MAP of 65, this TWA MAP below 65, the higher risk of mortality, acute kidney injury, and myocardial injury was there. The risk of mortality, acute kidney injury, and myocardial infarction were apparent at 85 millimeter mercury. So what this exploration of the electronic health record database is suggesting that below 65 is harmful, above 85 is also harmful. My final concluding remarks is, MAP may be a relevant goal for improving outcome in septic shock, but although in general, a low MAP strategy seems to be similar to a high strategy in terms of outcome, a single fixed value is not suitable for all patients. Optimal blood pressure target likely ranges from 65 to 85 millimeter mercury and probably lies between 65 to 75 in most millimeter mercury in most patients. Whether an individualized based approach will result in better outcomes than a protocol based approach, targeting like we do currently a predetermined level of MAP remains to be demonstrated. And one very important thing is it is not only about macro circulation. If you remember, although we don't believe in the EGDT reverse EGDT trial, but the microcirculation cannot be ignored when you are looking at the mortality and you are only looking at correlation of the MAP with mortality, 28-day or 60-day mortality. So I think more pragmatic study would be that includes the macrocirculatory targets also, and then separates the macrocirculatory data to say that whether the microcirculatory data and tells us whether the macrocirculatory has an impact in absence of a microcirculatory data. So that possibly will answer. So as of now, ladies and gentlemen, 65 to 75 would be a prudent approach. But I will not disagree with those who would go for a higher MAP in patients who are hypertensive. So the question is very much open as of now. Thank you very much.
After those 3 lectures on resuscitation, we'll now move on to another concept, which is de-resuscitation. I now invite Dr. Manu Malbrain from Poland to take over. Dr. Manu.
Hello, ladies and gentlemen. Let me introduce you the 7D framework of fluid therapy, and let me focus today on the resuscitation. Because if water is the problem and fluid overload or fluid accumulation syndrome is an issue, then maybe de-resuscitation is the solution. These are my conflicts of interest, and topic of today will be breaking some bad habits. So the 7D framework is on D1 definitions, D2 diagnosis, D3 the drug, D4 the dose, duration of therapy, de-escalation, and D7 is to documentation. D6, instead of de-escalation, which is lowering the amount of fluids, we can also actively remove them. So when we have D1 to D7 multiplied, we have D to the power of 7, or fluid stewardship. So the focus today will be on the drug, so when to start fluid removal and asking the 4 questions, and will be on de-escalation and even further the evacuation phase, fluid removal or de-resuscitation. So first, some definitions. Fluid balance, is the sum of the ins and the outs. Fluid overload is an old definition that is used to define a cutoff value of 10% of fluid accumulation from patient's baseline body weight. And we have early adequate goal-directed fluid management, is what we refer to as sepsis guidelines, the 30 ml per kilo within the first 1-3 hours. Late conservative fluid management, 2 consecutive days of negative fluid balances, and then late goal-directed fluid removal, and this is referred to as de-resuscitation. So while fluid overload is accompanied by hypervolemia, hyperhydration, and peripheral edema, hypervolemia will lead to peripheral edema, but the presence of peripheral edema does not mean that the patient is intravascularly hypervolemic. So maybe we should avoid the term fluid overload and talk about fluid accumulation syndrome instead. There's been a recent opinion paper out in intensive care medicine. It's available under open access. So let me redefine fluid accumulation. So it's an increase in percentage in body weight relative to admission body weight. It could be an actual increase or the cumulative fluid balance, all measured with bioelectrical impedance analysis. And the fluid accumulation syndrome is any degree of fluid accumulation with a negative impact on end organ function, and that may or may not be associated with capillary leak or the global increased permeability syndrome. There are many more definitions. I will not list them here, and maybe we'll discuss some during the rest of my talk. Fluid status is important. As we know, hypervolemia is bad, so we need to make a correct diagnosis. Hypovolemia is bad because there is hypoperfusion to the tissues. This can lead to organ failure and dysfunction. So how to achieve then normal volemia? If we look at the abdomen, the abdominal vessels form a very large capacitance venous pool where we can have vasoconstriction of the veins or hepatic vein vasodilatation. As a result, this may increase effective circular blood volume, sits between the stressed and unstressed volume. It has a high capacitance, but a low compliance compared to brain, heart, kidney autoregulation. So if we give a lot of fluids, there will be capillary leak, intestinal edema, ileus, abdominal pressure will increase, and this will decrease superior mesenteric artery flow. It's also important to recognize the abdominal west zones, which will relate to the interplay between central venous pressure, abdominal pressure, and inferior vena cava pressure. Because there is a relation between abdominal pressure and perfusion as measured with ICG-PDR. If you look at the normal ranges and you go to the higher abdominal pressures, you see that ICG-PDR is low. So now let's focus on the macrohemodynamics. We're always talking about fluid responsiveness and unresponsiveness. Both parameters can be accompanied with either a very low or a very high preload or volemia status. If you give more and more fluids, you will go from fluid underload to fluid overload. You will accumulate some fluids and you may end up with a fluid accumulation syndrome. And this may or may not be accompanied with peripheral edema or capillary leak, and what we will discuss as the global increased permeability syndrome. So there is also something which is called the fluid tolerance, which defines when giving further fluids will lead to deleterious effects on organ function. So it's the balance between fluid responsiveness and unresponsiveness, and on the one side, and fluid tolerance and intolerance on the other side. And combination of these will increase the risk for fluid accumulation syndrome. So if you're unresponsive and intolerant, there will be a very high risk. This is a healthy capillary, and this is the same capillary only a couple of minutes later after an insult. Again, these are normal capillaries in hamster cheek pouch, and this is 10-30 minutes after an insult to the peritoneum. So you can see that capillary leak not only occurs very fast, but also at a distance. So full fluid status really matters. And there are a lot of myths surrounding this, like septic patients are not always hypovolemic. Surgical patients also are not always hypovolemic. And the presence of sepsis does not mean that there are huge insensible losses. Likewise, peripheral edema does not mean that the patient needs to be given diuretics, and a low preload does not mean that the patient needs to be given fluids. So if we go back to the surviving sepsis campaign guidelines, we need to measure lactate and so forth and administer rapidly 30 ml per kilo crystalloids. So the 3-hour bundle has changed to a 1-hour bundle and has been added that we can also think of adding vasopressors. So let's move to D3, which is about the drug. And of course, we must not do harm. We must ask ourselves 4 questions: when to start fluids, when to stop fluids. Best fluid is the one that has not been given unnecessary. When to start fluid removal, which is the deresuscitation. And of course, we must avoid hypoperfusion. When to stop fluid removal, when the patient is too dry. But when it comes to fluids in sepsis, it's not a good idea to give starches, gelatins, salines in large amounts, not hypotonic solutions. So balanced crystalloids are a good first choice, and the fluid strategy may be more important than the fluid per se. If we look at the vast amount of fluids that are given, it's not for resuscitation. This is only 6%. More fluids are given for nutrition, 33%, or maintenance, 25%, or fluid creep, which is fluids that seep into the patient. And if we compare for maintenance hypotonic versus isotonic solutions, so on the left you have saline, and on the right you have hypotonic maintenance, you see that in healthy as well in ICU patients, hypotonic solutions result in a less positive fluid balance. So saline leads to a more positive fluid balance, plus 600, plus 900 in healthy in ICU after 48 hours. And the same is true for the sodium balance. So saline-containing solutions, it's after 48 hours, more positive sodium balance. And even for healthy kidneys, it takes a while to get rid of the excess sodium. So D4 is on the dose, and it's the dose that makes the poison, as Paracelsus nicely said. Let's move to D5. As the duration of treatment, of course, we mustn't use fluids to treat the numbers like a low blood pressure, urine output, or CVP. We must use fluids to treat the shock, and we must stop the fluids when shock signs are resolved. Brings me to D6, which is on de-escalation. In 2014, around the same time, 2 opinion papers came out alluding to the framework of dynamic phases of fluid therapy. There was the SOSD and the ROSE acronym. If you would ask Twitter, there's a clear preference for the ROSE acronym. So let's take a rose. You give water, which is fluid resuscitation, is the blossoming of the rose, resuscitation, optimization of organ function, organ support, stabilization of the organs, and then at some point de-escalation and evacuation of the excess fluids. Hence the ROSE acronym. If you plot this on the timeline, and on the y-axis, the fluid balance after the first hit, whether it's sepsis, trauma, burns, pancreatitis, fluids, or life-saving, fluid balance must be positive. Then comes the organ support, the stabilization, which is related to the second hit, which is ischemia reperfusion, and positive fluid balance is a biomarker for disease severity. The third hit is what I refer to as a global increased permeability syndrome, and negative impact on organ function. There we need to active removal of fluid, and of course we must avoid hypoperfusion. Hence the acronym the ROSE. And just to show you or tell you that the ROSE at the end is just a dry one, it's not a dead patient. I'm very happy to see that this ROSE concept has been taken up by other colleagues, for instance in neurocritical care, and we summarize this on everything you need to know about the resuscitation. So again, it's freely available, the different phases. But if you look at the different studies on fluid resuscitation in sepsis and critically ill, most of the big fluid trials randomized or started the study drug after 24 hours, so after the initial resuscitation phase. Only a few trials looked at the very early stages, and then some studies looked at late stages, and then we have the hemodynamic optimization trials within the first 24 hours. But no one single study took us through all the different phases. So after first hit, we need to rescue the patient with goal-directed therapy. And we need to optimize organ function, go for late conservative fluid management, stabilize organs, and then some patients will need late goal-directed fluid removal to evacuate and save the patient. So to guide these different phases, we can use macrohemodynamic parameters initially, like blood pressure, functional hemodynamics, passive raise. When these normalize, you stop fluids. And when there is a negative impact of fluid accumulation on end organ function, you look at oxygenation along water, abdominal pressure, maybe you evacuate, and then at the end, you must look at perfusion. Again, there's no one single study. We summarize this in the opinion paper, looking at the driven triggers to start fluids, which is the presence of shock. You stop fluids when there is fluid unresponsiveness, and you start fluid removal when there is fluid accumulation syndrome, and you stop when there is again risks for hypoperfusion. So the goal is to avoid global increased permeability syndrome. So what is this global increased permeability syndrome? It's a persistent positive cumulative fluid balance plus organ failure plus ongoing capillary leak. And this can be evidenced by an increase in lung water or abdominal pressure. Why is this so? Because a positive fluid balance is an independent prognostic factor for patients with sepsis, and restrictive therapies seem to be better than liberal ones. Because if we give fluids, there will be second, third space fluid accumulation, edema in the abdomen, there will be ileus, abdominal pressure will increase, vena cava will be compressed, reduced blood return to the heart, reduced cardiac output, reduced flow to the organs, and multisystem organ failure may occur, leading to kind of a vicious cycle. So the fluids that we see accumulating at the outside of the patient, like the Michelin Man, mirrors the fluids accumulated at the inside at each and every organ function. And this will lead to organ dysfunction, mainly also because of venous congestion and increased backward pressures. Is this also the case in COVID? Yes, of course it is. And especially in the first wave where we have patients with high body mass index, high abdominal pressure, especially going to put those in the prone position, it's ready for complications. So therefore, anasarca is not just a cosmetic concern, anasarca is bad medicine. So the big question is, okay, we understand that there is capillary leak and sepsis, and we need to have source control, fluids are life-saving, but they may accumulate and it may lead to a fluid accumulation syndrome. So some patients will need deresuscitation. But when? So when there is no spontaneous transgression from the ebb through the flow phase, and this is Mont Saint-Michel in France at low and high tide, and flow phase is what you see after tubular necrosis, you have the polyuric phase. So if the patient is not peeing normally and if is not evacuating the excess of fluids, so is remaining in the ebb phase of shock and not transgressing to the flow phase. So this is the persistent global increased permeability syndrome. So if you look at the timeline of the big fluid trials, there was this relief trial in 2018 comparing restrictive and liberal treatment. There was no difference in primary outcome. There was maybe more risk for AKI in the restrictive group. Later on, there were other studies like the Brandt-Stroop study from Denmark, 172 patients. And you can see that in the liberal group, there was more fluids, more body weight, and you see the more increase in fluid accumulation, the more complications. So you could ask yourself how restrictive is restrictive. And if you compare the relief with the Danish study, you can see that maybe the relief was not liberal enough and maybe relief was too restrictive compared to the other studies. So it's finding the separation between the two arms of the study. Is there any other data? Well, it may be that fluid overload may cause more endothelial damage, so initially the healthy and the sick capillary. Looking at some meta-analysis results, it's the same signal. Overall complication rates are less with restrictive, and it seems to be better with respect to length of stay and resolvement of ileus after abdominal surgery. Another meta-analysis, again, abdominal surgery, you see less complications. There may be an increased signal for increased AKI, but overall complications are less. So now we come to the recently published classic trial, New England Journal, looking at a large set of patients comparing restrictive and more liberal or standard fluid group. You see the primary endpoint was not different, but because of that, you could say otherwise by giving less fluids was the same outcome. So less seems to be safe, less seems to be more, because at least you can avoid fluid accumulation. But at the end, we need to individualize, personalize our care and identify that one patient that may need deresuscitation. So how do we do that? How do we assess hypervolemia or hyperhydration or fluid accumulation, and then how to guide deresuscitation? You could look at some clinical signs of fluid overload, but these are rather aspecific, like body weight, fluid balance. There are also biochemical assessment. I think it's interesting to see if you are fluid overloaded. There may be hemodilution, so a drop in hematocrit or total protein. Also, capillary leak may be increased, osmolality, some interesting parameters, and there may be signs and symptoms of ongoing infection and poor source control. Radiographical assessment, again rather specific, will be important to look at the heart. So what about low inferior vena cava collapsibility index? Look at this tracing. And if you ask again social media, people don't know whether the patient is intravascularly hyponormal or hypervolemic. Basically, we don't know. And in fact, this dilated inferior vena cava was the result of a pericardiac tamponade, and the patient was in fact intravascularly underfilled. So we need to have more information, and just looking at inferior vena cava has a lot of limitations. And for instance, the presence of high PEEP or auto PEEP or right ventricular failure or abdominal hypertension may play a role. So I wouldn't go for inferior vena cava collapsibility index, although the stethoscope is the ultrasound is the modern stethoscope. And could be used for other signs, for instance, the presence or disappearance of B lines. So clinical, biochemical, and imaging techniques, but let's focus on some other hemodynamic, organ function, and some options for the future. So hemodynamic assessment, well, again, many parameters, but I wouldn't go for barometric preload indicators, rather go for volumetric ones. What about the absence of fluid responsiveness as a safety parameter for deresuscitation or volumetric preload? Xavier Monet and colleagues showed that patients without intradialytic hypotension did not have a change in cardiac index with the passive leg raise. So if you perform passive leg raise and there is increase in cardiac index, that patient may not be ready for deresuscitation. What about volumetric preload? I think it's important to correlate the end diastolic volumes with the ejection fraction, the global ones, with transpulmonary thermodilution. So the lower the ejection fraction, the higher the resting end diastolic volumes, and the corrected end diastolic volumes on the right may better indicate the true volemic status of the patient. What about other parameters like extravascular lung water, pulmonary vascular permeability? One of my favorites, intra-abdominal pressure. So let's have a look at lung water, and this is a retrospective study, 123 patients, where we found that a drop in lung water with 2 mL per kilo was a good prognosis factor. And if we define a responder as the one who drops the lung water, you see that they have a less positive fluid balance. And late conservative fluid management, remember 2 negative fluid balances, these patients had better survival and faster weaning, and the responders also better survival and faster weaning. So lung water and the dynamics of it seem to be interesting. What about PVPI, pulmonary vascular permeability index? If you have on the left hyperpermeability edema, it's the ratio between lung water and pulmonary blood volume, PVPI will be much higher in permeability edema and sepsis compared to cardiac edema. And again, Monet and co-workers were able to separate with a cutoff of 3 ARDS from cardiogenic edema. So that might be interesting as well. And abdominal pressure, if it's increased, you can decrease it by removing excess fluid. So a high abdominal pressure, and again, the trend over time may be an important parameter. Maybe some other monitoring tools in the future, and I will discuss briefly, like bioelectrical impedance analysis, circulating blood volume calculation with radioisotope labeling of albumin and VEXUS. So what about the ratio between extracellular and intracellular water? And we just finished a study 101 ICU patients comparing to healthy volunteers. But if you look at the ICU patients, you will see that the volume excess calculated with BIA was much higher in non-survivors, and also the ratio between extracellular and intracellular, indicating that there is some capillary leak and fluids are leaking out into the interstitium. So what about this isotope dilution techniques? From one study in septic patients where they calculated circulating blood volume. And in this study, it was shown that patients treated with this technology received less fluids there was also reduction in length of stay and mortality. So this again seems promising and may come close to true circulating blood volume. What about this Vexus venous access by ultrasound? Has been very popular recently in discussions. So you look at hepatic portal intranasal venous Doppler, and then you calculate the Vexus score, and this seems to be predictive for AKI congestion better than CVP. So maybe one more thing, which is about the frusemide stress test, has been used by nephrologists to detect kidney injury, kidney reserve. So you give a dose and look at your output. If it's below 200 in the next 2 hours, this may be a poor prognostic parameter. So if you identify the patient and you want to de-resuscitate, then you can go for a PAL treatment, combination of a high PEEP. You squeeze the fluids out of the alveolus into the interstitium, and then you give the hyperoncotic albumin. You track the fluids into the intravascular space, and then after 30 minutes each step you give the diuretics and you can clear the lungs. We looked at this retrospectively, matched control. So the PAL group had higher PEEP, higher albumin, because it was substituted, and after 1 week of treatment, cumulative fluid balance was in balance, and this resulted in better oxygenation, lower abdominal pressure and lung water, and again better survival and better weaning. So the combination of early adequate and late conservative, or early liberal and late conservative, may have an impact on outcome. And if we compare some of the studies, early conservative, late conservative may have even better prognosis. So restrictive fluids compared to the liberal ones. And again, if we have this heat plot and look at the combination of early liberal and late restrictive, that may carry the best prognosis compared if you give too little initially and then too much too late, may have more adverse outcomes. Because I've said hypovolemia is bad, but hypervolemia may even be worse, because then you have interstitial edema and gut dysfunction, increased morbidity, mortality. And patients with concomitant heart disease may have a more sharp U-curve, so they may have problems more rapidly. So we need to do the right procedures, give drugs, fluids, inotropes, vasopressors, and then maybe de-escalate diuretics or remove fluids with CRRT, because both hypovolemia and hypervolemia may carry the risk for mesenteric hypoperfusion. So the last D7 is about documentation, and I'm very happy to see that the study of Marshall and McDougall is published, and over the years, introducing fluid stewardship, they were able to reduce fluid use from 0.65 liters per day to 0.4 liters per day, and from 5 liters per day to 3.7 liters per day. This is what happened at 5 in Scotland, and in Brussels, we had the same result, minus 1.5 liters per day or minus 0.2 liters per day. So, having said that, I hope I convinced you that perioperative fluids are not innocent bags of water, but they are drugs and should be considered accordingly. Think about this 7D framework. So today we discussed 4 questions in fluid removal and evacuation. Think about personalized, individualized fluid therapy. For that, you need a fluid team with doctors and nurses, and I think it's about time to start fluid stewardship in your ICU, in your hospital. So I would like you to go home with the knowledge that fluid overload is defined by cutoff value of 10%, but let's forget that. So now we talk about fluid accumulation syndrome, is any increase in cumulative fluid balance from baseline body weight with new and organ dysfunction. It's associated with increased morbidity, length of stay, ventilator days and mortality, and organ failure and think about this global increased permeability syndrome, it's all organ functions. Gibbs is the absence from the ebb to the flow phase. So how to guide clinical lab and imaging is rather specific. You could use point of care ultrasound if you use preload volumetric ones. The absence of fluid responsiveness is interesting. Look at the impact of fluid accumulation on organ function, lung water, PVPI, abdominal pressure. Avoid hypoperfusion by close monitoring. And I think in the future, bioelectrical impedance analysis, circulating blood volume, maybe EIT, didn't mention it, are promising. And don't forget venous congestion score. Having said that, I invite you to join the Fluid Academy, as well as the next Fluid Academy days on November 26th in Brussels. Thank you for your attention.
After that excellent lecture, we'll now move on to something else. We'll go to gut microbiome by Craig Cooper-Smith. And I've received a few questions, which I will be forwarding to Dr. Manu Malbrain. And once I get the answers, I'll forward it to the respective delegates. Thank you. Dr. Craig Cooper-Smith.
Hello, my name is Craig Cooper-Smith. I'm very honored to be here today. I'd like to thank the organizers for their invitation. I'm going to be speaking to you today on targeting the gut microbiome and sepsis. My disclosures are listed here. So to start with the gut microbiome, it's important to mention that there are 40 trillion, with the TR, microbes living inside both yours and your patient's intestine. This is at least as many cells as you have inside your body, with nearly 100 times as many genes. And under basal conditions, there are 1,000 different types of bacteria, taxa, living inside your gut lumen. This is taking that incredibly complex 40 trillion bacteria living inside of you and bringing all of it down to a single dot. The methods behind this are complex, but what you'll note are the red is us, as we're hitting here today, healthy people, and the blue are our patients. And what you see is there's almost no overlap between our microbiomes in health and the microbiomes of our patients in the intensive care unit. Similar results are seen in children. Well, you'll note the difference between ICU patients on the left in red, pediatric patients on the ward in the middle in blue, and healthy pediatric patients on the right. This occurs remarkably rapidly. In fact, we see dramatic changes to the gut flora within 6 hours after admission to the emergency department. These are some examples of what happens to the microbiome in critical illness. The first is a study of 34 ICU patients and 15 controls. They saw extreme individual differences in 13 critical ill patients, about a third of them, with a single bacteria genus making up more than 50% of the entire gut microbiota. And in a different study, again a small study, but of 14 ICU patients, there was the emergence of ultra-low diversity communities in a third of the patients containing only 1 to 4 bacterial taxa. That's remarkable if you think about it. We have 1,000 types of bacteria in our intestines, and yet a third of our patients might literally only have 1 to 4 different types of bacteria living inside of their intestines. The gut microbiome also has distant effects. Another small study of 15 patients on mechanical ventilation compared to healthy controls. And what they found was upper and lower respiratory microbial diversity decreased within 24 hours of intubation, but remarkably, the lung community was dominated by gut-associated bacteria. And an ecological analysis demonstrated that the lower GI tract was the most likely source of post-sepsis lung bacteria. In addition, in a study of mice who were given intra-abdominal sepsis via cecal ligation and puncture, researchers were able to find gut-associated bacteria in the brains of mice 5 days after intra-abdominal sepsis. Here's a study that came out this year showing that both gut bacteria and gut fungi, the bacteria biota and mycobiota, are both associated with 28-day mortality amongst critically ill patients. The causal nature of this interference needs obviously be further investigated, but there's a clear association between patients being admitted to the ICU and those who die in terms of the diversity of their microbiome. So what changes the microbiome in critical illness? A lot of this is already known. First and foremost, in and of itself, critical illness changes our microbiome. It's nearly impossible to do this study in people, although it can be done in things like trauma. It can also be done in animals. And ultimately, simply being critically ill, just the changes that happen within us, change our microbiome. But it's not as simple as just critical illness, because there's many things that we do that unintentionally change the microbiome. When we give antibiotics, the whole intention of giving antibiotics is to kill bacteria. Our goal is to kill pathogens, but while we're trying to kill pathogens, we're also killing bacteria that live inside of us. We give opiates to take away pain in our patients, but opiates actually have a profound impact on the microbiome. Proton pump inhibitors are used to prevent stress ulcer in the ICU, to prevent GI bleeding, but they work by changing the pH in the stomach. Normally, the stomach has a very low pH and it's sterile. However, when we prevent this acidic environment, bacteria can overgrow, and that changes the microbiome. And finally, tube feedings clearly change the microbiome theoretically, although this has not been as well studied in the intensive care unit. All of which leads to the question, can we alter the microbiome at the bedside? So there's multiple things that we can theoretically do to the microbiome. We can increase so-called good bacteria by giving probiotics, by giving prebiotics, which can be turned into probiotics, by giving symbiotics, a combination of probiotics and prebiotics. We can transplant bacteria via stool transplant, fecal microbial transplant, and we can decrease the so-called bad bacteria by selective decontamination of the digestive tract. And each of these has been shown to work to some degree. So the first thing we can do is to so-called increase the good bacteria. I have the number of references in PubMed, just in general, and also between what they are and sepsis on the day that I'm recording this talk. So probiotics are exogenous live organisms, so-called good bacteria. Prebiotics are non-digestible nutrients that stimulate commensal bacterial growth. And again, symbiotics are the combination of both probiotics and prebiotics. By far, the best studied have been probiotics. So, are probiotics effective? Here are 3 different meta-analyses, all published, as you see at the bottom, between 2020 and 2022, looking anywhere between 2,000 and about 5,000 patients. And you see here reduction in the incidence of ventilator-associated pneumonia, duration of mechanical ventilation, some showing changes in length of stay, none of them showing changes in mortality or diarrhea. So do probiotics work? Well, there's clearly different results depending upon which studies are included. There is some degree of consensus that ventilator-associated pneumonia is decreased and that mortality is not changed. However, the conclusions are limited by low quality of evidence, heterogeneity of study design, and outcome measures. Which probiotic to use? When to start it? how long to keep it going for. And despite the fact that each of the meta-analysis I just showed you has been published in the last 2 years, including this year, they're actually already out of date. Why is that? Well, this study came out in JAMA, the largest study that we have. Effect of probiotics on incident ventilator-associated pneumonia in critically ill patients, looking specifically at the effect of lactobacillus in preventing ventilator-associated pneumonia in 44 intensive care units in Canada, the United States, and Saudi Arabia, a study of about 2,600 patients, with the primary outcome being ventilator-associated pneumonia. And what we see here when we go to the conclusions is, amongst critically ill patients requiring mechanical ventilation, administration of lactobacillus resulted in no difference in the development of ventilator-associated pneumonia, suggesting the results do not support the use of at least this probiotic in critically ill patients. And for those who like to see visually what the results of the study are, you'll see that there was no difference between lactobacillus and placebo in medical or surgical or trauma patients, in younger or older patients, in patients who are frail or not frail, in patients who received antibiotics or did not receive antibiotics, and in patients who pneumonia was the primary diagnosis or not. But importantly, there was actually an increase in adverse effects in the group that got lactobacillus. You see 1% versus 0.1%, and serious adverse effects, again, being very low, but only being present in the lactobacillus group. Based upon this, in August of 2022, a new meta-analysis came out, Probiotics in Critical Illness, a systematic review and meta-analysis of randomized controlled trial, including this study. And the conclusion of this is there's low certainty evidence that probiotics or symbiotics during critical illness may reduce ventilator-associated pneumonia, hospital-associated pneumonia, ICU and hospital length of stay, but probably have no effect on mortality. So again, this is larger. This is including the data that I just showed you. This is now 65 randomized controlled trials, 8,400 patients. The largest trial is the one that I just showed you at 2,600 patients, which makes up about a third, a little more than a third. And so what you see here is that probiotics may reduce ventilator-associated pneumonia, and you see the relative risk of 0.59 to 0.89 in a confidence interval, as you see. And at the same time, probiotics probably have no effect on mortality. You'll see the confidence interval clauses 1. And post-hoc sensitivity analysis without high risk of bias negated the effect on ventilator-associated pneumonia, hospital-acquired pneumonia, and hospital length of stay. And that's important. So again, all comers, it looks like there's a decrease in ventilator-associated pneumonia. But again, a post-hoc sensitivity analysis, taking out high risk of bias studies, actually takes away the effect. Also worth mentioning is this. Human gut studies question probiotic health effects. This is based upon 2 studies that came out in Cell. And through a series of experiments looking inside the human gut, researchers showed that many people's digestive tracts actually prevent standard probiotics from successfully colonizing them. And in addition, taking probiotics to counter antibiotics could actually lead to delay of normal gut bacteria and gut gene expression. I do wish, however, to emphasize this other study. This is looking at symbiotics. This study was done in India, and this is looking at infants. So this has moved away from adult patients, and now we're talking about neonates to infants. This is a huge study, nearly 5,000 infants who weighed at least 22,000 grams at birth at 35 weeks of gestation. They were randomized to oral symbiotic preparation, lactobacillus plus fructooligosaccharides, or placebo. And there was a markedly significant reduction in the sepsis and the death risk of death. As you see, 0.6, not crossing midline for the confidence interval, 0.5 to 0.74, and significant reductions in culture-positive lower respiratory tract infections. Now, it's important to mention that these are neonates, and the microbiome in neonates and the immune system are remarkably different in neonates than they are in adults. The next thing we could possibly consider is stool transplant or fecal microbial transplantation. which is the transfer of intestinal microorganisms from a healthy donor via an infusion of liquid suspension of stool, with the intent of restoring the normal microenvironment in a person with altered gut microbiota. If I asked everybody listening to me today, have you seen a stool transplant? Some of you would say yes. Most of you would say no. And if I said, does this sound disgusting? Almost everybody would say, this sounds disgusting. And I confess, in theory, this does sound disgusting. Taking somebody else's stool and transferring it into one of us or our patients sounds disgusting. Until we think about this. So this is really, it's nearly a decade old now. This is really what got us talking about stool transplants. Duodenal infusion of donor feces for recurrent C. difficile colitis. Note, this is not ICU patients. These are non-ICU patients, but people with recurrent C. diff. And they were treated with either oral vancomycin followed by bowel lavage, or oral vancomycin followed by stool transplant, with the primary endpoint of being cure after 10 weeks. And the study was stopped early. This is absolutely remarkable. Efficacy, oral vancomycin, 31%. Vancomycin and bowel lavage, 23%. Oral vancomycin and stool transplant, 94%, with minimal adverse effects and restoration of microbial diversity. And since then, here's a meta-analysis looking at 37 studies, including 7 randomized trials and 30 case series. And stool transplant was more effective than vancomycin with a relative risk of 0.23 in resolving refractory and recurrent C. diff. There's literally nothing that we do in medicine that I can think of that has a relative risk of 0.23, which is frankly remarkable, and a resolution of 92% as opposed to 20 to 30%. So why isn't this standard of care in the intensive care unit? Well, we have to think about the impact of giving bacteria to a patient who already has an altered microbiome, who likely is immunosuppressed, and the impact of doing that is unknown. And even more so, the majority of critically ill patients receive antibiotics. And as soon as we give antibiotics to a stool transplant, we're going to alter the stool transplant. So with the guarantee, essentially, that initiation or continuation of antibiotics will certainly alter the microbiome, there has to be a commitment to stopping antibiotics prior to and after receiving a stool transplant. It's also important to note this cautionary note. This is a very small case series in the New England Journal of Medicine, but this is looking at stool transplant given for C. diff and 2 patients who developed extended spectrum beta-lactamase producing E. coli bacteremia after they underwent stool transplant in 2 independent clinical trials, linked to the same stool as the donor by genomic sequencing, and one of the patients died. So we have to be careful when doing this. But in select cases, should stool transplant be used in the ICU? Well, here's a small case series, but this is a case series of everything that's been published on of stool transplant in the ICU, showing, in fact, in 5 patients, in every one of them, after C. diff was excluded, the stool transplant was effective. So here's a new technology that may make the technology easier to use and actually more standardized. So this came out this year, published in the New England Journal of Medicine, SER 109, an oral microbiome therapy for recurrent C. difficile infection. Once again, not in ICU patients, but important. This is a phase 3 double-blinded randomized placebo control in which patients had 3 or more episodes of C. diff, in which they were randomized to either SER 109 or placebo. And I actually find the best description of this not in the paper, but in an editorial that came out in Science. The new pill is derived from human feces, purified to winnow down the resident microbes. Stool from pre-screened donors is treated with ethanol, which kills many viruses, fungi, and vegetative bacteria, those in a state of growth and reproduction. And what's left behind are bacteria that can form hardy, thick-walled structures called spores, many of them from the common phylum Firmicutes. Bacteria in this group are valuable because they can compete with C. diff in the gut, taking its space and its food and its carbon sources. The firmicutes also changes the composition of the bile acids in the intestine, making the environment less hospitable for C. diff. Again, getting back to the New England Journal article, 281 patients screened, 182 enrolled. And what you see is, in just this taking this pill, using the spores, there's a remarkable decrease in recurrent C. diff, 12% versus 40% in the placebo group. The final thing I'd like to talk about is selective decontamination of the digestive tract. SDD aims to prevent or eradicate oropharyngeal and intestinal carriage of pathogenic microorganisms without adversely impacting the remaining microbiome of the patient or the ICU at large. Importantly, it's actually not that selective because it targets both normal and abnormal flora, although it doesn't cover low-level pathogens like anaerobes, strep viridins, coag-negative staph, Symetricocci. So, the data behind SDD is actually very robust. This is a meta-analysis of 41 trials published last year with 11,000 patients ventilated for at least 48 hours. The reporting quality of the majority of the studies was poor, but SDD, topical plus systemic antibiotics, decreased mortality with an odds ratio of 0.84. You see the confidence interval there, leading to 48 deaths per 1,000 patients. It also reduced respiratory tract infections remarkably with an odds ratio of 0.43, 238 fewer infections per 1,000 patients. That's remarkable, and it's based upon a lot of trials. But if I ask people listening to me, most of you would say, I've never seen SDD, I don't use it, and I don't know anybody who uses it. Despite the fact that even topical antibiotic prophylaxis appeared to decrease mortality and may reduce respiratory infections, albeit with low certainty evidence. So why don't people use this, except in the Netherlands? It's because essentially all of these trials were done in ICUs in a single country, that is the Netherlands, with low baseline antimicrobial resistance. So when I give this talk and I ask for a show of hands and I'm in person, I say, who here uses this? If people are in the Netherlands, everybody raises their hands because of that remarkable data. If people are in other countries, they don't because of concerns about breeding antibiotic resistance. And so here's actually a study that came out fairly recently in JAMA, decontamination strategies and bloodstream infections with antibiotic-resistant microorganisms in ventilated patients, a randomized clinical trial. So standard care was chlorhexidine, body washings, hand hygiene, and then each ICU was assigned in random order to 3 separate 6-month interventions with mouthwash, standard oral decontamination, it's a mouth paste with colistin, tobramycin, and nystatin, a standard decontamination of the digestive tract, which is the same mouth paste, but also a gastrointestinal suspension with the same antibiotics, all applied 4 times a day. And the main outcome was ICU bloodstream infections, and 28-day mortality was a second outcome. A huge study, 8,600 patients. And ultimately, you see the conclusion at the bottom. Amongst patients receiving mechanical ventilation in the ICU with moderate to high antibiotic resistant prevalence, the use of mouthwash, the use of standard oral decontamination, and the use of SDD was not associated with reductions in ICU-acquired bloodstream infections. And it was also not associated with any change in mortality. As you see up higher, the adjusted odds ratio for 28-day mortality was a little over 1.0, and for SDD was 1.03. That clearly crossed confidence interval of 1. So in conclusion, the microbiome is converted to a pathobiome in the ICU, and it mechanistically plays a role in mortality from sepsis in preclinical studies. I didn't have time to show you that, but work from my laboratory shows that if you have genetically identical mice that you get from different vendors that have different microbiomes, simply changing the microbiome is sufficient to change mortality. The microbiome can be targeted in the ICU in multiple ways, by giving so-called good bacteria, by giving stool transplants, by trying to get rid of bad bacteria. And while each of these shows promise, each of them is limited by logistical concerns and heterogeneous and often low-quality data that prevents any of these today from being standard of care. Once again, I'd like to thank the organizers so much for inviting me to speak here today. I am tremendously honored for the invitation. Thank you.
After that informative lecture, let's move on to a different format. We'll now move to a panel discussion on the appropriate use of antibiotics in my patient, led by Dr. Subal Dikshit and other panelists. Over to you, Dr. Subal.
For this panel discussion on the rational use of antibiotic. At the outset, I would like to thank the organizing committee of Sepsis Forum of India for giving us the opportunity to participate in this excellent session. For this rational use of antibiotics, we have got faculty from Pan India. We have got Dr. Rajesh Mishra from Ahmedabad. He is the president of the Indian Society of Critical Care Medicine. Dr. Palepu Gopal is a senior intensivist from Hyderabad. Dr. Ashit Hegde is a physician and intensivist from the PD Hinduja Hospital. Dr. Shushruta Bandyopadhyay from Amri Hospital in Calcutta. And Dr. Khalid Khatib from Naule Hospital Medical College as an intensivist there. So we'll be discussing the rational use of antibiotics, and for this session, it is very important for us that how antibiotics should be used very rationally, and that is the most important part, because we've seen that antibiotics have been used left, right, and center, and that predisposes to development of resistance and the development of resistant bugs. So I like to go a case-wise approach and taking a small case of a 40-year-old with cough, fever, with dyspnea for 1 day, which increased since about 4 hours. The patient was tachycardic with a pulse of 100, a BP was 94/50 with a respiratory rate of 32. The saturation was 85 and the ABG showed a pH of 7.3, PCO2 of 30, PO2 of 50 and a bicarb of 35. So definitely he was quite hypoxic, and this is the X-ray chest which shows a consolidation on the right side. So I would like to start off the ball rolling from Dr. Hegde from PD Hinduja Hospital, that, sir, what are the common organisms causing community-acquired pneumonia in the intensive care unit in India and worldwide? What has been your experience?
Thank you, Subal. So actually, we are talking only about severe community-acquired pneumonia now, because we are talking about the ICU.
Yes.
So the predominant organism causing pneumonia worldwide, there is of course Streptococcus pneumoniae. So all over the world, the major organism responsible for severe community-acquired pneumonia remains Streptococcus pneumoniae. Now, of course, number 2 and 3 probably would be the viruses because of COVID and H1N1. I think now H1N1 and COVID would be number 2 and 3. And then, of course, we have other organisms like H influenza. In patients with certain risk factors, which I'm sure we're going to discuss, patients might have gram-negative bacilli like Klebsiella and Pseudomonas. And also, depending on certain risk factors, you might sometimes occasionally have Staph aureus causing a bad pneumonia. Other things in our country, of course, we need to think about it. Sometimes, of course, of the atypical organisms, even Listeria is a common, is not Listeria, Legionella is a cause of severe community-acquired pneumonia of the atypicals. Legionella is the one that causes severe community-acquired pneumonia. And in our country also, milioidosis probably sometimes comes with severe community-acquired pneumonia, and probably missed, especially from the coastal areas and the rice growing areas, but probably needs to be thought about. And also TB can sometimes come up in our country, can present as a severe community-acquired pneumonia. So that's the sort of the epidemiology of severe community-acquired pneumonia all over, more or less the same all over the world. A few things in our country we need to think about.
Yeah, thank you, Dr. Hegde. Yes, as what Dr. Hegde said, common is Streptococcus, gram-negative, sometimes Haemophilus influenza, Klebsiella, of course, Mycoplasma, and less common are Staphylococcus and Legionella, which sir has already covered up, which are there. So I would like to go to Dr. Khatib with the second question from Naule Hospital. Okay, what are the risk factors for multi-drug resistant pathogens for community-acquired pneumonia in intensive care unit? Dr. Khalid? Dr. Khalid? Okay, we'll come to this question later. I think he must be having some connection issues. So I would like to go to Dr. Rajesh Mishra as the president of the ISCCM. Rajesh, how will you assess the patient? We have seen that the common pathogens have come up with community-acquired pneumonia. This patient has come up with a BP of 90 systolic with a patch. So what is the severity and how will you assess that this patient risk stratification? Where will the patient get admitted, to the ward or intensive care unit or to a HDU? Rajesh?
So, Subal, there are for community acquired pneumonia, there has been some scoring system called community acquired pneumonia severity scoring, and then curve 90, curve 65, where you look for the consciousness and urine output, respiratory rate, and age. And but what commonly being done and followed is the clinical assessment. So in clinical assessment, if pneumonia, community acquired pneumonia comes to you with respiratory failure or with the sign of septic shock, he or she definitely goes to ICU and needs ICU admission. In between all those patients with community acquired pneumonia who are not hemodynamically stable, who are not having altered sensorium, who are not having any sign of any organ dysfunction, they may definitely go to the ward under strict observation if they are high risk factor. So simply what we do, that if you have community acquired pneumonia and if any organ dysfunction, definitely you go to ICU. If there is a septic shock, if you need oxygen, that means you need vasopressor and oxygen support, you definitely need to go to oxygen. But if you do not have any organ dysfunction and you are high risk, like age is only 65 plus, definitely this patient even go to the ward, they are under strict observation. So it's a clinical assessment with some signs which helps us in diagnosing. Definitely there are, like most commonly used is the curve 65, which is being used, and definitely helps in keeping the patient at the appropriate place and even even telling us the prognosis. So this is how we do it. Subal, you are muted.
Sorry. Yeah, thank you, Rajesh. Very nicely covered. And very nicely covered by Rajesh to assess the severity, that depending upon the severity index or the curve 65 criteria, which consists of urea, the respiratory rate, what is the systolic blood pressure, the diastolic blood pressure, and if the age is above 65, we are giving 1 points to each for a total of 5. And of course, what Rajesh said, yes, if the patient's curve 65, 1 and 2 require ward, but if the severity is very high, these patients have to be very aggressively managed into the intensive care unit. So we'd like to cover up the risk factors when the patients get admitted to the intensive care units. We have seen that he's a pneumonia, now we have admitted. So what are the risk factors which multi-drug resistant pathogens which are caused into community acquired pneumonia in ICU? So I request Dr. Khalid to take this question. Dr. Khalid?
So Khalid is not there, I can take this question.
Okay, yeah, please, Rajesh, you can take this question, please. Rajesh, you can take this question. Khalid, I think, has got connecting issues.
So, Subal, traditionally it has been recognized that exposure to antibiotic, a frequent visit to the hospital where there are MDR bug, you become exposed to MDR bug and then you have risk. So simple risk are that if we in last 90 days you have been taken antibiotic for 2 or 3 days, for more than 2 or 3 days, or you are admitted in a hospital for 2 or 3 days, you have visited where you are on dialysis, where you frequently visit to the hospital. So there are some traditional risk factors, but bottom line is that we should suspect MDR in all immunocompromised patients who get hospitalization, who has been hospitalized in last 90 days, or for some reason or other somebody has taken particularly fluoroquinolones and cephalosporin for more than 2 to 3 days in last 30 days. Apart from that, person has graduate neonatal facilities, dialysis facilities, or chronic facilities, and he is high immunocompromised, particularly those who are diabetic, having any other chronic organ disease. So these are the patients who have high risk to get exposed to MDR bug, or having high risk to acquire MDR bug because they have taken inappropriate dose of antibiotic which was not needed. So these are some risk factors we should always assess to get to know that the person is maybe having MDR bug to begin with from community.
Yes, thank you, Rajesh. What Rajesh has said, this is just to summarize it. If the age is more, if this patient is being admitted to the other hospitals where he received antibiotics, second hospitalization in the preceding, home infusion therapy, including antibiotics, ongoing immunosuppressive therapy, or home wind care. So I would like to go to Dr. Shushruth from Amri Hospital in Calcutta. Okay, Shushruth, how early should antibiotics be initiated in patients with community-acquired pneumonia who get admitted to the ICU? When do you start giving antibiotics?
Yeah, I guess the ICU admitted pneumonia patients, community-acquired pneumonia patients should be either in respiratory failure or shock or both. If a patient comes to the ICU with a septic shock or a respiratory failure, then you should be even hours count, even minutes count for starting antibiotics. You will have to send the cultures, whatever is possible, blood, if the sputum, or you can do a bowel and you send that for culture and try to start the antibiotic within 1 hour. A broad spectrum antibiotic, we should cover all reasonable pathogens which might be expected in that area or the hospital. That is the objective of this 1 hour delay in starting antibiotic actually increases the mortality by 6% for septic shock patients, and that is a classic trial. It has been validated several times.
Yes, absolutely. I completely agree that yes, appropriate antimicrobial therapy should be initiated as early as possible within the first 1 hour, after of course obtaining all the microbiological cultures, which is very, very important. And this is as per the guidelines where through the Indian Society of Critical Care Medicine, where majority of us have been the faculty there. So, Dr. Gopal, I would like to request you to take this question. When this patient is admitted for empirical therapy of patients with community-acquired pneumonia, should a combination therapy should be used, or you would like to give only a monotherapy, considering that we know that certain patients have got admitted to other hospitals, they are sick, they have been shock or septic shock. So what is your experience and your thought process on this, whether a single or a dual or monotherapy?
Thank you, Subal, for giving me this important question. As the previous speakers panelists have said, after we stratify the location of the patient and categorize the patient and send the initial sample, the onus of starting an early antibiotic therapy falls on the intensivists and their group. I think in the last decade and a half or so, we have traveled from monotherapy to combination therapy. But having said that, we need to know our local flora and fauna. And it depends on whether fundamentally what is the character of your local infections. They are pseudomonal or non-pseudomonal. If it's pseudomonal, along with covering the atypical bacteria, community-acquired pneumonia should be treated with a combination therapy, and the evidence for that seems to be reasonably strong according to the guidelines, ICCM guidelines. So we can start a beta-lactam combination with clarithromycin, one of the macrolide antibiotics. But sometimes a patient may be allergic to penicillin also, so we will be caught maybe about 5% of our population have some proved or unproved allergy to antibiotics, the penicillin group of antibiotics. Then we can go for the fluoroquinolone group, which has wide cover. And this wide cover comes with a small cost that like levofloxacillin, because in India, the incidence of tuberculosis, especially on the western side of the country, is very high. Bombay is called the capital of, Ashit will be telling, Bombay is called the capital of multi-drug resistant tuberculosis. So we have to preserve some drugs to treat this kind of patients. So before using fluoroquinolones, we have to take care of that particular angle and make sure, of course, the samples have to be sent along with the AFB. So to summarize, it has to be a combination antibiotic, preferably with beta-lactam and a macrolide group. If not, a fluoroquinolone along with non-macrolide and non-beta-lactam group.
Yeah, thank you, Dr. Gopal. The recommendations also say that yes, those patients should receive a combination therapy of empirical antibiotics covering all the causative organisms, and what Dr. Gopal rightly said, that yes, you should know the local flora for what antibiotics also this patient has received before, and of course by obtaining the cultures. And the recommendations here are already given. A beta-lactam antibiotic, of course, with a macrolide should be covered to cover up the atypical spectrums. So Rajesh, I would like to take this question for you, that when you will consider giving anti-pseudomonal cover should be added in patients with community-acquired pneumonia, If required, what are the preferred antimicrobials of choice we will consider to use for these anti-pseudomonal cover?
So, Subal, again, to be very specific, exposure to this third generation cephalosporin, particularly ceftriaxone, and exposure to quinolones. Make a special case where person become susceptible to get pseudomonas infection. Apart from the other, so if I have a patient who is immunocompromised, have been exposed in last 30 days to 30 days on cephalosporin, particularly third generation cephalosporin like ceftriaxone or quinolones, this patient will be a risk factor to have pseudomonas. Apart from that, person exposed, particularly if you have visited to the ICU or hospital where the risk of pseudomonal infection is very high, and you have visited to the hospital and after that you have become sick, then this person will be again become long-term patient, particularly immunocompromised transplant patient who are on multiple drugs. If they become sick and they come to us with infection, they will be another risk factor to have pseudomonal infection. So having said that, for pneumonia, if I know my antibiogram, I go according to that for pseudomonas, because the MDR pseudomonas is not simply sensitive to the routine medicine. So either you have to go for BLBLI or if you go for the carbapenem, then combination of carbapenem plus other medicine. Like if I have to use here, I will probably go for if I suspect that this patient is very sick and pseudomonas infection, I will not simply go with plain meropenem rather than meropenem or colistin or piperacillin plus combination of if you are going for the high dose of cefepime-tazobactam. So we need to really know. I cannot. But what I select, if I suspect pseudomonas, I will go with the piperacillin-tazobactam in a maximum possible dose. Or if very high risk patient and there is resistance for piperacillin-tazobactam, then maybe I can go for the colistin and meropenem combination. Many a time when we are really getting after culture that pseudomonas is positive and it's MDR infection, then probably these are the patients who need sometimes colistin plus cefepime plus ciprofloxacin, or many times other combination where we have to treat MDR pseudomonas. So I mean, initially, even I suspect also pseudomonas, even if I suspect it is MDR, if MDR, then colistins and mero. If it is not suspect, I suspect just pseudomonas, then piperacillin-tazobactam should be fine, but sending culture and trying to find out this. So depending upon stage, because we get all combination of the patient, and depending upon severity and exposure, that's how we decide.
Thank you, Rajesh. The risk factors, what you already covered, that those patients who have got COPD, asthma, those or patients who have used antibiotics before, or those patients who are using steroids, or those who are immunocompromised, there is a chance for multi-drug resistance of pseudomonal infections. And exactly what Dr. Rajesh Mishra covered, like you would like to use a cifrazidime or cefperazone or piperacillin-tazobactam or ceperazone-sulbactam along with imipenem, meropenem, simipenem, and of course sometimes a combination with aminoglycosides or anti-pseudomonal fluoroquinolones should be considered. Dr. Khatib, from Noble Hospital, I would like you to take this question. When you would consider MRSA cover to be added as an empirical regime for community-acquired pneumonia in intensive care?
Thank you, Dr. Dixit, for that question. I think whenever the patient has close contact with an MRSA patient who's already having, or if there is close contact with somebody who is a carrier for MRSA, then in situations where patient has already suffered from influenza in the recent past and now he comes with community acquired bacterial pneumonia, then one must suspect MRSA. If the patient is either athlete or army recruit or a prisoner, and in patients who are men who have sex with men, or IV drug abusers, if the patient is a regular sauna user, then one must suspect MRSA and act accordingly. Also, if there is recent antibiotic use, then I think one must suspect that whatever community acquired pneumonia this patient is having, it might be because of MRSA. Now coming to situations. So when to suspect in patients who are having community acquired pneumonia, when to suspect that MRSA might be there. Especially as I have already said, if this community acquired pneumonia is occurring after a bout of influenza, or if the pneumonia is showing on chest X-ray or HRCT, if it is showing cavitation or it is a necrotizing pneumonia, if there is rapid increase if there is associated massive hemoptysis, or if there is neutropenia, or if whenever you examine the patient, if there are erythematous rashes on the patient, then I think one must suspect MRSA, and antibiotics to cover MRSA must be added. Dr. Subal.
To Dr. Khatib. So, as you rightly said and covered all the points, that of course close contact with a patient of MRSA, drug abusers, sauna users, or even in case patients of healthy patients, if you find that there is a cavitation or the necrotizing pneumonia along with rapid increase in the pleural effusions or massive hemoptysis or with rashes, you should consider to add it. And of course, MRSA for consideration, vancomycin or teicoplanin should be added to the regime, and linezolid should be used for vancomycin intolerant patients or those patients with VRSA or those patients having renal failure. Dr. Hegde, I would like you to take these questions. When should anaerobic cover be added to empirical antibiotic regime for community-acquired pneumonia in ICU?
Honestly, anaerobes as a cause of severe community-acquired pneumonia is not that common. But obviously, you consider that in some risk factors, so patients basically risk of aspiration, somebody with esophageal obstruction, somebody who's little upturned, somebody who's comatose, or if you're witness an aspiration, somebody with poor dental hygiene, these are things where you might suspect, anaerobic pneumonia. But having said that, I think the risk of anaerobic pneumonia for severe COPD is very, very low. So you probably in real practice would start anaerobic cover. Sputum is really foul smelling, or there's an associated lung abscess or an empyema. Otherwise, fortunately or unfortunately, many of the drugs, in any case, cover anaerobes, but specifically you would think of adding anaerobe cover, I would say in these situations where the sputum is really, feculent, or there's a lung abscess or an empyema. Otherwise, in the run-of-the-mill severe community-acquired pneumonia, even if they have the risk factors, I wouldn't straightaway add. But of course, you think about it in the risk factors that I mentioned about essentially risk factors for aspiration, either obstruction to the airway or or the obstruction to swallowing or an obtunded airway.
Right. Thank you, Ashit. We would like to go to the next questions. And before we go up, just to sum up what he rightly said, those patients who are having aspirations or purulent discharge present of lung abscess, empyema, or necrotizing pneumonia, you should consider to add anaerobic cover. And of course, empirical antibiotics with anaerobic cover should be considered in the treatment in the presence of clinical spectrum of only these conditions of abscess or necrotizing pneumonias. And the antibiotics having anaerobic activity would be amoxicillin clavulanic acid or clindamycin or moxifloxacin. And piperacillin, tazobactam or carbapenems can be used as empirical therapy due to anaerobic cover, because carbapenems also cover the anaerobes. And of course, the occasional duration of treatment should be for 6 weeks, but you need to individualize it depending upon the response to the severity. Dr. Palipu Gopal, I would like you to answer what should be the optimum duration of antibiotics for use of community-acquired pneumonia in ICU?
Once again, Subal, this is a very practically challenging and useful question about the duration of antibiotic therapy. Though in our textbooks and many of the recommendations that are supplied by the industry, the antibiotic duration is said to be 5 days or 7 days. Unfortunately, there's no strong evidence for each type of antibiotic or the combination. Possibly the answer to this question lies in 1, what kind of infection it is; 2, what is the characteristics of the infection in the patient; 3, what is the response of the patient. Depending on these 3, for example, if it is a non-pseudomonal community-acquired pneumonia, usually we give this antibiotic therapy from anywhere between 7 to 10 days, even in ICU. For example, this is a pseudomonal pneumonia, you may extend the therapy up to 14 days. At the same time, if there is structural lung damage along with necrotizing pneumonia and patient is really sick, you may have to extend it up to 3 weeks. But having said that, as I said, The evidence levels of this are weak, and repeatedly there are data coming out saying that the current durations which are following are questionable and further research needs to be done on this.
Yes, thank you, Dr. Gopal. As you rightly said, ICU patients require duration of about 7 to 10 days. Those patients with pseudomonas or aspiration pneumonia, you should give it for 14 days. Or those patients with MRSA or necrotizing pneumonia, you can consider to give it for about 14 to 21 days. Of course, it should be treatment should be individualized depending upon the organisms, the response, and also what is the severity of the disease and the complications. Rajesh, what is your opinion on the use of procalcitonin? Should it be used to determine the duration of antibiotic administration for CAP in ICU?
So, honestly speaking, there has been very varied evidence for the use of procalcitonin. The only thing which has been convincing so far is that if you want to stop antibiotic and you are not sure about that you are dealing with infection or not, and then probably you do procalcitonin 1 or 2 times, and if it is normal, you can stop antibiotic. Apart from that, should procalcitonin be used for duration of antibiotic decision? Not very convincing data, although people have tried to do maximum study in community-acquired pneumonia. Even the serum level, cutoff level has been reduced for CAP, but it's still not very convincing. So I will not suggest that somebody should decide the duration of antibiotic based on procalcitonin is as good as doing CBC or any other marker. Clinical judgment is better, but if we are sure about that you are not dealing with infection, and if you are procalcitonin normal, then you can stop antibiotic. But not to take it like that you do daily procalcitonin and then you decide about the duration of antibiotic, probably not very convincing.
Thank you, Rajesh. As the recommendations from the guidelines, procalcitonin can be used along with clinical judgment for de-escalation of antibiotics in CAP in ICU patients treated beyond 5 to 7 days. But of course, you need to take into consideration what Rajesh said. It is just an inflammatory markers, and sometimes you need to individualize the therapy and not just follow the results of the biomarkers, what are there for us. Dr. Gopal, I would like you to take these questions. What are the causes for non-response to the treatment?
Yeah, sometimes even though you choose the correct antibiotic for the suspected organism according to your geographical or institutional location, the response may be disappointing. Some patients within the given time frame that is expected to respond or improve don't respond, and these non-responders usually may be early or late. Early is before 72 hours. When you give a correct antibiotic, though literature says early antibiotic improves the condition, they may not actually respond, and the late responders may take more than 72 hours to do that. The causatives may be, even if the patient responds, patient may be still go on a mechanical ventilation or maybe in septic shock, even they cause a concern of non-response. The causes for this non-response can be vertically divided into infection-related and non-infection related. The infection-related responses basically are atypical infections, complicated infections, or coexisting viral infections, or nosocomial infections, or a secondary hospital infection that may occur. Whereas you are targeting a community-acquired pneumonia, patient may end up with an MDR infection and may not show the response. Then the slow response may also be because of the physiological and other pathological characters of the patient, that is, the patient's old age, coexisting comorbidities, multi-drug resistant organisms, gram-negative organisms, etc. If patient is not responding in 8 to 9 days, of course, like Dr. Rajesh Mishra says, procalcitonin can also be used for the direction of the therapy. Then among the non-infectious causes, there may be structural lung disease, complicated infections. Patient may be suffering from a coexisting malignancy. Patient could have formed empyema or a lung abscess, etc. Or he could be suffering from pulmonary edema, pulmonary embolism. So a systematic approach to the patient to rule out infectious and non-infectious causes will probably improve the response rate of the slow responders or non-responders.
Yes, thank you, Palepu, for the excellent coverage of taking into the entire causes of infection-related causes where it is a treatment failure, where it is usually defined as a persistence or a progression of pneumonia resulting in the need for ventilation or development of septic shock. And sometimes it may be as early within 72 hours or late after 72 hours. And the causes, as I said, that the infection of the pathogens are not covered by the initial antibiotics, or they are atypical pathogens, sometimes H1N1 or tuberculosis, secondary nosocomial infections which occur, or infectious complications could occur because of parasynpneumonic or parapneumonic effusions or lung abscess or even empyemas, or certain patients are slow responders, that these patients improve with therapy, but the rate is very slow, especially in those patients with comorbidities or the senior citizens or those with severe infections with Legionella or Staphylococcus are usually slow responders, and about 8 to 10 days may be required for clinical improvement. But as you also rightly said, sometimes non-infectious causes, like those patients who have got malignancy, metastatic or lung cancer, those who have got a foreign body, or those patients with pulmonary embolism or infarction or a lipoid pneumonia, these patients, some of non-infectious causes are non-responders or they're very slow responders. So before we end up, one last question here that I would like Shushruth to take up this question. What further workup would you like to do into these non-responders? Is there any specific way you would like to respond or analyze these patients if the patient is not settling? Because of course the relatives will definitely ask us that despite giving higher antibiotics, this patient is not responding. So any further
basically this is the intensivist nightmare, that you have diagnosed a pneumonia, you've given a big antibiotic, and the patient is ultimately not responding, or after responding, the patient has, condition has worsened again. So already the list has been given by Dr. Gopal about what might be the possible causes of non-responding. And what we need to do is that we need to look for this non-responding causes of this non-responding one by one. We'll go for new imaging, possibly a CT scan and a repeat chest X-ray to see whether there is a fresh pneumonia, whether there is any collection like empyema, whether there is any underlying malignancy, lung abscess. We go for that. We need to have fresh samples. If the patient is intubated, we can go for endotracheal suction and send for again fresh cultures. Or if the patient is not intubated, we will go for a BAL and send for cultures. We have got now newer modalities like BioFire, which can pick up the odd infections or a host of viral pneumonias, which should not be covered by the standard antibiotics. And we also look for non-infective causes like associated heart failure. We have said that we might be doing an echocardiogram with tissue Doppler. We may go for BNP, NT-proBNP, and we might be looking for a pulmonary embolism with D-dimer, with Doppler. And when we do the CT, we might do a CT pulmonary angio. And we might also look for those other odd diseases like ANA. And then for this polyangiitis, we need to look for the ANCAs. So this will more or less cover the second set of diagnosis, which might be there, we might have missed, or which might be stopping or getting the patient, stopping the patient from getting better. So we need to do this sort of tests.
Yes, thank you, Shushruth. You have exactly covered up that, of course, further non-responders should be analyzed with the bronchoscopy, or of course by doing further culture sensitivity with rapid molecular diagnostic techniques. Look for other kind of diseases or collagen vascular diseases. Look for any heart failure by doing echo or embolism by doing D-dimer or venous Dopplers, and of course further evaluation with sonography and chest. So I would like to thank all the panelists, Dr. Rajesh Mishra as the president of the ISCCM, Dr. Khalid Khatib, Dr. Palepu Gopal, Dr. Ashit Hegde, and Dr. Shushruta Bandopadhyay for sharing their valuable time and sharing their thoughts on this Sepsiscon, third Sepsiscon, which is going to be held virtually. And of course, we'll be discussing about the rational use of antibiotics into the intensive care units. So this is the questions what we have discussed for their open discussions, and we'll be very happy to take questions in case if there are any from the audiences which are there. Again, on behalf of the Sepsis Forum of India, I would like to thank all the faculty for taking out their valuable time, and we'll be very happy to take questions from the chat box which the viewers are typing into the chat box. Thank you all, and thank you very much.
Thank you, Dr.
Thank you.
My colleagues.
Thank you.
Thank you.
Let's move on to the last lecture, which is by Shrikant Srinivasan. It's about new antibiotics in the pipeline. Dr. Shrikant.
Good day to my seniors, friends, and colleagues. At the outset, I'd like to thank the organizers of Sepsiscon to have invited me to talk about what is new in the antibiotic pipeline. So it all starts with this gentleman, Alexander Fleming, who got the Nobel Prize for discovering penicillin. But at the same time, he added a rider. He said that it's not difficult to make microbes resistant to penicillin in the laboratory by exposing them to concentrations not sufficient to kill them. There is the danger of that an ignorant person may underdose himself and hence by exposing his microbes to non-lethal quantities of the drugs make them resistant. So at the same time as he discovered penicillin, he also gave a prophetic warning regarding the hazards of underdosing, inappropriate dosing, abuse of antibiotics, and the possibility of rise of resistance. And since then, my friends, we all know that we have been facing a rampant spread of bacterial resistance. There's a rise in what's called the MDR, or the multi-drug resistant pathogens, which are bacteria that shows resistance to at least 3 different classes of antimicrobials. And we risk entering the so-called post-antibiotic era in a few years, where infections which are apparently under control can easily turn into lethal threats because the bacteria will become resistant to the drugs and there'll be no therapy available to us. If you were to take Enterobacteriaceae as an example, prime example, since the 1940s, when penicillin was initially discovered, it was totally sensitive. By the 1970s, the bacteria became smarter. They started developing penicillinases, and the resistance to penicillin started to come up. By 1990s, we had extended spectrum beta-lactamase producing organisms, ESBL organisms. And by the year 2000, we have carbapenem resistant bacteria, we have XDR, we have PDR, that is extended drug resistant bacteria, and pan-drug resistant bacteria. So the future looks bleak, especially when there are advanced molecular mechanisms of antibiotic inactivation by these bacteria. These may include production of inactivating enzymes, penicillinases, carbapenemases, beta-lactamases, changes in alteration in the antibiotic targets, reduced cellular permeability, production of efflux pump leading to increased outflow of antibiotics or ejection of the antibiotics from the cell. So these are the primary 4 mechanisms of resistance of bacteria. And we have this global problem of MDR pathogen, which goes by the acronym of ESCAPE. These include our Enterobacteriaceae, Pseudomonas, Acinetobacter, and Klebsiella. And the mechanism of resistance is numerous. We'll talk about them in the future slides. Along with that, we are also having a rise in Staph aureus, the MRSA and the GISA strain, and the Enterococcus faecium, which could be the VRE strain. In all healthcare sectors, travel, importation, local spread, these are contributors to the spread of these strains. Since the world has become a global village, there's been an excessive amount of travel, rampant use of antibiotics, scanning of strain from one place to another place. And there's a large diffusion of resistance, horizontal transfer of mobile genetic material, successful clones, which lead to further proliferation of these drug-resistant bacteria. If I were to give you an outlook about this is published in 2014. This is still old. You can actually see that Indian subcontinent is endemic when it comes to NDM producers. This is one of the most resistant kind of bacteria which can be possibly there, and it's resistant to one of the type of carbapenemases, which is resistant to most of the antibiotics, and very few antibiotics actually work against it. And India is also the endemic to OXA48 producers. The end result of both of these is that there is an increased consumption of the only antibiotics which are still susceptible, that is the polymyxins, and there's an increased consumption of colistin. So the WHO has taken steps. It has listed priority pathogens for research and development of new antibiotics to push in new antibiotics into the pipeline. The GAIN Act in US for generating antibiotic incentive now, and there's innovative medicines, new drugs for bad bugs, ND4BB. These are the various projects which have been launched by different countries to try to develop new medicines, and they have classified into critical, high, and medium based on the priority of development. And the critical group belongs to Acinetobacter, which are carbapenem resistant, Pseudomonas, which are carbapenem resistant, Enterobacteriaceae, which are carbapenem resistant, and third generation cephalosporin resistant. So this is the most critical focus on which the entire R&D is trying to bring in new antibiotics. So when we talk about carbapenem resistances, that was the focus. What are these kind of resistance? So they are molecular mechanisms, and they are classified as per Ambler classification into class A, which includes the KPC, which includes the GES, the IMI. So whenever you have an antibiogram which says KPC, it is a class A kind of mechanism of resistance. Class C is AMP-C, and class D is OXA, which is the most common cause. Class B belongs to metallobeta-lactamases, the zinc metallobeta-lactamases, and this includes the dreaded NDM, IMP, VIM. So these are the several classes of carbapenemases, or the enzymes which inactivate carbapenems and make them resistant. So this is the mechanism of resistance for carbapenems. And if you can see why the metallobeta-lactamases are the most dreaded, you can see the B, class B, which is resistance against penicillin, cephalosporins, first, second generation, third, fourth generation, BL-BLI combination, as well as carbapenems. Close on its heels are the KPC and the OXA. So the KPC still being sensitive to BL-BLI, but resistant to carbapenemases, while the OXA strains are also equally dreaded because they are resistant to BL-BLI and carbapenems. So if in a summary, in a nutshell, most of the Enterobacteriaceae are AMP-C, ESBL, or carbapenemases. When we talk about Pseudomonas and Acinetobacter, they have a similar kind of mechanisms of resistance. They are usually aminoglycoside modifying enzymes, multi-drug efflux pumps, or purine mutations. So these are the major mechanisms of mutations for the various subgroups or species of bacteria. So what to do? So if you were to go from the bench to the bedside, we can have two type of therapies. First is that we can have research for novel targets. We can have new and novel structures, newer molecules, which can be produced, and then that can focus on killing the bacteria through newer mechanisms. But the problem is that these new molecules have unknown toxicology, resistance, efficacy, bioavailability is not known. So a rather better focus would be to use known targets, that is older antibiotics, with a combination with a novel or a new derivative, which makes the older antibiotic more potent, more effective. So the advantage being that it's predictable, newer interaction sites, lower the MIC of these agents, and that product, which can be a combination of a novel agent and an old agent, can work equally well. And this is the major focus for R&D which is going on, and it applies to all the 30 new drugs which are in the late stage of clinical development. So these are the drugs which have been developed since the year 2018 which is in the pipeline to 2023. We'll talk about a bit of them. Meropenem, Vabrobactam, cefiderocol, plazomycin, evracycline, phosphomycin. We'll talk about these things. Aztreonam avibactam is also coming into the market now. It's marketed by the name of Zavicefta. Imipenem, Velibactam, and we can talk about the combination of Aztreonam with avibactam. So this is in a nutshell in which we'll talk about. Most of these studies have taken place in complicated UTI, carbapenem-resistant organisms, and complicated intra-abdominal infections. So the ongoing phase 3 trial is to expand the spectrum into healthcare-associated pneumonias, VAPs, and CRBSIs. So they are still work in progress, but a lot of information and a lot of trials have shown promising results. So let's start with the first one. Ceftolozane and Tazobactam. So Tazobactam is old, beta-lactamase inhibitor, and ceftolozane is a newer drug or a novel drug. It's a novel expanded spectrum cephalosporin, which has been marketed by the name of Zerbaxa. So this combination is there, and it has been approved in December 2014. It's a fixed combination of this novel agent with the Tazobactam in the combination of 1 gram of ceftolozane with 0.5 gram of tazobactam given 8 hourly. The idea behind producing this drug was to increase the activity against Pseudomonas aeruginosa. So it specifically tried to counter the mechanisms of resistance against Pseudomonas aeruginosa, which was predominantly impermeability, efflux pump, or AMP-C overproduction. As I told you, Pseudomonas and Acinetobacter, they work through these three mechanisms. So this was specifically designed to overcome this kind of resistance. So it had good activity on ESBL and AMP-C producing Enterobacteriaceae, but it was not active against carbapenemases producing mutations like KPC, MBL, OXA48. It had very limited activity against Staphylococcus, predominantly urinary excretion, 92%. So it is very good for complicated urinary tract infections and pyelonephritis and complicated intra-abdominal infections. And documented infections due to ESBL, which are susceptible to this combination of ceftolozane, tazobactam, which could include ESBL or AMP-C producing Enterobacteriaceae. Now, other focus of research has been on to beta-lactamase inhibitors. So we have a beta-lactam, which is an older drug, but now we have novel beta-lactamase inhibitors. The older beta-lactamase inhibitors were clavulanic acid and tazobactam, as we saw in the previous one, ceftolozane, tazobactam. But now the research is towards newer BLI or beta-lactamase inhibitors, which are these include avibactam, relibactam, vorbactam, and nacubactam. So these are the 4 new BLIs which are in the pipeline, and a few combinations are already in picture. For example, ceftazidime avibactam, astronam avibactam, ceftalorine avibactam, meropenem vorbactam, imipenem relibactam. So these are the combinations which are available in the market now and are undergoing phase 2, phase 3 trials. So one of the most newest things which are being used quite commonly right now is the existing beta-lactam with avibactam combination. Most commonly ceftazidime avibactam or Zavicefta, or a combination of astronam and avibactam. So ceftazidime avibactam or Zavicefta is 2 grams of ceftazidime and 500 milligram of avibactam, and is given 8th hourly. It's active against ESBL, AMP-C, some carbapenemase producing Enterococcus also, KPC and OXA. But the problem is it is not active against metallo-beta-lactamases. That is the class B. So NDM strain, which is inherent or predominant in India, VIM, IMP, these will not, ceftazidime avibactam, any combination with avibactam will not work. It does not have any activity against gram-positive or anaerobes. It is undergoing phase 2 trials versus carbapenem in complicated intra-abdominal infections and complicated UTI, and phase 3 is already completed with regards to this. So it is approved since April 2016 by the FDA for intra-abdominal infections, urinary tract infections, hospital-acquired pneumonias, and infection due to drug-resistant gram-negative organisms, where the other options are limited. So these are the various phase 3 studies which are done: Reclaim, Recapture, Reprove, and Reprise. So all of these were non-inferior studies, which say that when we compare it with meropenem, for regards to treatment or cure, it is equivalent. And obviously, it has to be used in those cases where the resistance to carbapenemase is there, especially when you talk about KPC or OXA, but not NDM. So if you were to compare between ceftolozane, tazobactam versus ceftazidime avibactam, novel, old, novel, then we see that ceftolozane tazobactam has activity against some gram-positive activity, and it has some anaerobic activity as well, while this does not have. This is purely gram-negative. But on the other hand, this has some activity against KPC and variable activity against OXA, whereas your ceftolozane tazobactam is not effective on carbapenemases at all. It is specifically designed for Pseudomonas aeruginosa and its mechanism of resistance, its efflux pump and porins and so on. So it has been found to be superior to other regimens for Klebsiella pneumonia bacteremia. So when you compare it with other regimens, because when we have a drug-resistant Klebsiella and we have a bacteremia because of drug-resistant Klebsiella, which is resistant to carbapenems. So the other combination which we have is with colistin, carbapenem with colistin, which we give a lot, meropenem, colistin, imipenem, colistin, or carbapenem with aminoglycoside. So it's found to be much more superior to that. The cure rate is much more higher, 85% versus 48% for the rest. So definitely a much more superior drug when we talk about The 90-day survival is also much higher, 92% survival as compared to only 50% survival when we have carbapenem and colistin combination. Newer thing is aztreonam and avibactam. We were talking about ceftazidime avibactam. Now we talk about aztreonam and avibactam. Now the aztreonam is hydrolyzed by many serine beta-lactamases, class A, ESBL, but not by metallo-beta-lactamase. So the only advantage of adding aztreonam to avibactam is that we know that avibactam had no activity against metallo-beta-lactamases or the NDM strain, class B. But when we add aztreonam to avibactam, this helps us to overcome that resistance to NDMs. So combination of aztreonam, avibactam improved the activity against MDR, including all carbamazepinases, including KPC, MBL, OXA48. The MIC levels came down. Susceptibility was 99.9%. There is a caveat though, it is less active against MDR pseudomonas and no activity against acinetobacter because these two act through different channels. They act through efflux pump and porins and not through carbamazepinases predominantly. So for multi-drug resistant Klebsiella, this would a combination of aztreonam, avibactam, especially in MDM strain, would be quite useful. However, no large-scale trials have been done till date. Multicentric trials have been done till date to say that to prove the 100% efficacy. It has the stability is also much more as compared to the other combinations which we can use. Coming to imipenem relebactam, it's an irreversible inhibitor of class A, ESBL, KPC, and class C, that is AMP-C. It produces a 64% reduction in the MICs of imipenem for KPC producing Klebsiella pneumonia. So most of these BLI inhibitors reduce the MIC of the old drug. It has a good activity against the AMC, overproducing Pseudomonas aeruginosa also, but it is not active against, again, metallo-beta-lactamases and not active against OXA strains. So it is predominantly only for KPC, ESBL, and AMC, not for class B or class D. So it has no or little activity against Acinetobacter pneumoniae. Coming to this combination, meropenem vorbarbactam. Now, vorbarbactam is a novel cyclic boronic acid inhibitor of beta-lactamase. Just because of the boronic ring, it produces a much more potent drug. It has a prolonged binding to the KPC enzyme. It has, by itself, vorbarbactam has no intrinsic antibacterial activity, but it restores the activity of meropenem by reducing the MIC levels to a manageable range. And KPC producing CRE, a 16 to 32-fold decrease in MIC. It has no activity against MDR, Pseudomonas aeruginosa, or not against Acinetobacter species. Just like the previous drug, Pseudomonas and Acinetobacter will fall out of this purview. So what vorbarbactam is that it reduces the MIC levels to a more susceptible level. It does not produce a change in meropenem activity. But when we talk about meropenem activity against Pseudomonas or Acinetobacter, if the primary cause of resistance is an efflux pump or low permeability, it will not help. These are the various trials, the Tango 1, the Tango 2, the Tango 3 for meropenem vorbarbactam combination. They were a non-inferiority trial, which showed that there was better cure. And when you compare it to best available therapy for documented or suspected CRE infection, it has got reduced mortality, higher clinical cure, reduced adverse effect, including lower nephrotoxicity, because colistin is associated with higher nephrotoxicity, but this has much lower nephrotoxicity, and no susceptibility or change during or after treatment. So there's no resistance per se so far to it. Pharmacological properties, it is excreted unchanged in urine, no hepatic elimination, so it can be used in hepatic failure. Half-life is around 1.5 hours, same for meropenem and vorbarbactam, so you don't have to change the dosing regimen for that. Low serum binding and adjustment in renal impairment is the same as for meropenem. Clinical indication, complicated UTI, including acute pyelonephritis, and dosage is 4 gram. There's 2 gram of meropenem plus 2 gram of vorbarbactam in a 3-hourly infusion every 8 hours for around 2 weeks. Now coming to this drug, this is a Cytophore cephalosporin. This is cefiderocol. Now this is something which has a much more better stability against beta-lactamase. It binds to the ferric ions and causes rapid uptake into the cells of the bacteria because of this rapid uptake through cytophoric ferric ion transport system. And hence this is not affected by the classical efflux pump, the same problem which made the other drugs resistant to Pseudomonas or Acinetobacter. It is not affected by the efflux pump mechanism. So this ability to enter cells and avoid being thrown out by efflux pumps produces a very good susceptibility across a large range of Pseudomonas, Acinetobacter, MDR, Enterobacteriaceae, and Xenotrophomonas maltophilia, with more than 99.6% of the strains being sensitive to it. If you see the MIC levels for CRE, for Pseudomonas, for Acinetobacter, it's got the least MIC ranges. If you can see this has got the least MIC range for all three, cumulative MICs. And these are the various trials which has been used for complicated UTI, healthcare-associated pneumonias, VAPs, bloodstream infections. So it has shown pretty promising results, and that is one drug which is sensitive across the wide spectrum of carbapenemesis, sensitive against Pseudomonas also, it's sensitive against Acinetobacter also. So it's still showing a very good sensitivity response. Now coming to a novel aminoglycoside. Plasmomycin is a novel aminoglycoside, a derivative of cesomycin, which is a type of gentamicin B, but it is more similar to amikacin in its structure. It is the only aminoglycoside agent which is sensitive against Providentia species. And it's all resistant which are otherwise isolates which are otherwise resistant to aminoglycosides like gentamicin, tobramycin, or amikacin, it becomes sensitive to plasmomycin. So it's active against AMP-C, ESBL, and CRE. It's inactive still against class B metallo-beta-lactamases. It's active against Staph aureus, coagulase negative Staph. It's got limited activity against Acinetobacter. Half-life is 4 hours. Renal excretion is 87%. It is less nephrotoxic and cochleovestibular toxic. So as compared to other aminoglycoside, it has got a much better safety profile. And in fact, it is bacteria as compared to other aminoglycoside which are predominantly bacteriostatic. This is bactericidal. So this has got a much range. Dosage is 15 milligram per kg once a day. Once a day dosing is there. Half-life is 4 hours. Renal excretion 87%. Currently, phase 3 trials for complicated UTI and severe carbapenem-resistant Enterobacteriaceae infection. So it has found to have higher microbiological eradication rates as compared to meropenem. Survival benefit has also been seen, and safety profile is similar to meropenem, with a much lesser nephrotoxicity as compared to other aminoglycoside. A novel tetracycline, eravacycline, which is a broad spectrum tetracycline. It acts to the same mechanism as other tetracyclines do, binding to 30S ribosome and inhibit the protein synthesis, bacteriostatic. But the advantage is that because of this novel structure of eravacycline, which has got a pyrrolidine acetamide ring, it evades most of the resistant mechanism of other tetracyclines, which are efflux pumps or ribosomal protection proteins. So these are the two mechanisms by which tetracyclines are rendered ineffective, but it overcomes those kind of resistance. So spectrum is gram positive, gram negative, class A, B, and D. So a very wide spectrum tetracycline, effective against Acinetobacter and anaerobes. Dosing is IV and oral route. Oral route is only 28% bioavailability. Administration once a day. Elimination half-life 48 hours. Biliary excretion 70%. Renal excretion 15%. And no dose adjustment in moderate renal or liver failure. This has, however, just like other tetracyclines, no activity against Pseudomonas aeruginosa or Burkholderia species. So just like tigecycline does not work against Pseudomonas, neither does this work against Pseudomonas or Burkholderia species. But it is 2 to 8 times more potent than tigecycline against CRE and Acinetobacter. Clinical studies are for complicated intra-abdominal infection and complicated UTI, non-inferiority, higher cure rates. So this is a review of the major activity. We talk about KPCs. Most of these newer combinations we have talked about, they are effective against KPC producer. When we talk about metallo-beta-lactamases, the NDM strain, the type B, only cefiderocol, plasmomycin to some extent, evaracycline to some extent, and fosfomycin to some extent. When we talk about MDR, Pseudomonas aeruginosa, then we have ceftolozone tazobactam, which I said was predominantly specifically for Pseudomonas aeruginosa, targeting its resistance patterns, and ceftazidime avibactam. And we have a reasonable amount of drugs. The major problem comes in Acinetobacter species because very few drugs are effective against it. Cefiderocol and plazomycins are promising agents for Acinetobacter. Evercycline is also a promising agent against Acinetobacter. Just prior to we finish, which is one more thing which is coming up, is drug-resistant C. difficile infection. Now, C. difficile infection, the best drug of choice is metronidazole and vancomycin. But a new drug which has been produced for there's an increased incidence of resistance against metronidazole. Almost 40% resistance is seen across some strains, and we should understand that toxin A and toxin B are not inhibited by metronidazole or vancomycin for that matter. And both metronidazole and vancomycin affect the gut microbiota. So effectively, if you affect the gut microbiota, because they are affecting all the microbes, so then treatment of Clostridium difficile really becomes more difficult. So this new drug, renilidazole, is a synthetic antibiotic class of benzimidazole, rapid bactericidal activity specifically against C. difficile. It has a unique mechanism of action. It binds to the minor groove of DNA. It's poorly absorbed through the gastrointestinal lumen, so it acts like a decontaminant agent, and it acts specifically against C. difficile. And the best thing is that it has reduced action against the other gut microflora, making it the ideal drug for CDI. The MIC value is much lower. It's much closer to fidaxomicin. And in vitro models, it shows that it has activity against toxin A and toxin B as well. So it also reduces the level of inflammation by showing we can see the reduction in interleukin 8 levels. So this seems to be a very promising drug for drug-resistant C. difficile infection. In conclusion, several new promising drugs have been there. New BL-BLI combination, novel aminoglycoside, novel tetracycline. Superiority to the current regimens or the best available therapy is not completely assessed. It requires randomized controlled trials, but there's definitely much more promise. Mind you, there are very few options for metallo-objective lactamases or non-fermenters like Acinetobacter, as I just showed in the previous slide. Most of these agents are IV, so most of them don't have oral routes. Fewer options for resistance mechanism other than beta-lactamases. For porin and efflux, which are there in Pseudomonas and Acinetobacter, there are fewer options. There are more options against carbapenemases. Higher costs, and how long these new combinations will work, really we do not know, because the bacteria are ever evolving. So there are already incidents of resistance against Sepsiscon avibactam. So this is just a temporizing measure, probably, and the best way to stop further resistance will be appropriate stewardship pattern, a practice development of rapid diagnostic techniques allowing targeted therapy and not broad spectrum therapy to every single patient. Thank you, and I conclude my talk, and I thank the organizer.
We come to the end of all the scientific talks. Now I would like to invite Dr. Jirpe to say a few words before we conclude. Dr. Jirpe, sir?
Yeah, Khalid, no doubt it was a very exciting session today morning also. Yesterday we had a very good lecture series, and of course it was within time limit. And today also we try to cover every aspect of the sepsis in terms of the fluid management as well as the fluid responsiveness, newer antibiotic, and of course that panel discussion on the antibiotic use. So with this, we are coming to the end of this 2 session online, our 3rd annual Sepsiscon, and I'm sure every year we'll try to continue this activity in the same enthusiasm and with the same quality and with the everybody's blessing. Thank you. Thank you.
Thank you, sir, for those kind words. I now conclude the session, and I would like to thank Sepsis Forum as well as ISCCM Pune branch for their support. Thank you. I hope we'll all meet physically next year, hopefully.
Yeah.
Thank you.
Khalid,
Yes,
before that, I would like to appreciate and thank our sponsors. Without them, it was not possible. And also our partner, current partner of this platform, Meetings and More, Girish and Shekhar and Saho. Everybody did their job excellent, and we were able to finish our commitment in time and in a proper way. And the Cipla, Aventis, Biocon, and Thermo Fisher, these are our
partners for this educational activity. We appreciate their support and thank them for this thing. And of course, the ICSM Pune branch who always supporting with us. So Dr. Abhijit Deshmukh is the current chairperson, and Khalid, the secretary of the ICSM Pune branch. We appreciate your support, and in future also we need your support to promote the sepsis through Sepsis Forum. Thank you. Thank you.
Thank you, sir. Thank you. I now conclude the session. Thank you all. Thank you to the delegates.